everybody. Thank you for coming. My name is John Abraham. I serve as the Arizona affiliate leader for Final Exit Network. We are by far the most active affiliate in the country. Glad you could be here. For those of you who are new, well, where did Ann go? Ann is new. Is Ann still here?
Yeah.
Okay. We are a Right to Die organization, and although this meeting is not about Right to Die in particular, that will come up. If you don't agree with that, that's okay. We do have other programs that do address that, even including a demonstration of the inert gas method, which is the method we most highly recommend. We had two major complaints last time. The TV was too low. You can all see the TV now, I hope? Okay. And some of us were too soft-spoken, so now we have a mic. You can hear me okay? All right. I do have a number of preliminary announcements. This is being videotaped, so that you know. Anybody refusing to be videotaped? Thank you all for your consent. Any no votes? So the ayes carry. I want to first introduce our leadership team. If you have questions and I'm busy chatting with somebody else, these are the people to bird dog. Jay Fleur, stand up. Jay Fleur Lohman, Cheryl Rays, Cheryl and John Stetson, and Tim, pouring the coffee, Tim Lohman. I want to thank Robin for filming this. Thank all of our leadership team for, we meet about, I don't know, 5-6 times a year to plan our programs, evaluate our programs, and so on. Thank you especially for hosting us here at Milagro. And we do have a number of materials here. Bear with me. Okay, if you can still hear me, we have a number of things. We have bumper stickers. Everything here is free except the book. But we have bumper stickers. I hope you might consider taking one. We have membership brochures. I beg you to take several of these and leave them in your community. Give them to friends. Give them to neighbors. Leave them in the hospital waiting area. Leave them in the car service waiting area, wherever. Same thing with the newsletters. We have a lot of newsletters here. Please take several and help distribute those. We have buttons. We have a couple of different buttons. We have those with which I am adorned, and we have Let Me Die Like a Dog. Those are free also. And the only other thing that is not free is the best book on the subject, How to Get the Death You Want, a Practical and Moral Guide, which I had published just last year. So we do have a couple of those.
John, let me say, I have read it and I highly recommend it.
Thank you, George. Read it and highly recommend it. Anybody else?
Yep.
Very good, very good. All right, all right.
Can I give a
Yes.
plug for that book? Take a look at it. It's so comprehensive. It covers so many questions related to this whole process, and it's just going to be very, very helpful for you. And I have got a couple of copies myself.
We give them away to all the relatives, you know.
Now these guys are my best customer. I think they bought about a half a dozen at least.
John worked hard on it, and he's had a lot of experience. It's a good book.
Thank you. Thank you. Another unsolicited testimonial. Okay, advocacy training. Merriam-Webster says an advocate is one that pleads the cause of another one that supports or promotes the interests of another. That's what we're here for today. We're here to learn how to be a good advocate on behalf of yourself or someone else anytime you encounter a medical institution. You all have blue folders with a number of documents in them. You should have on the left-hand side of the folder, you have Advocacy, you should have announcement about our new Arizona program of the Advanced Directives Workshop. That takes place next week, March 10th, right here. There's information there. You should have the Advanced Medical Directive Worksheet and Advanced Directives Values Worksheet, a listing of what makes a good advocate. What does your advocate need to know about your current health condition? Surrogate decision-making, what helps and hampers. Surrogate is the same as advocate. Some states call it a proxy, an agent. Actually, the legal term in Arizona is healthcare agent or surrogate. I call it advocate. Other states call it an advocate. These things are all state-specific. You have another document saying, let's see, the next one is questions you might ask your doctor. On the back of that is questions to ask yourself. Saying goodbye, communicating at the end of life, some tips on getting your wishes honored. Okay. On the right side, you have an evaluation form. At the end of the meeting today, can everybody stay until 1 o'clock? Okay, we're going to ask you to fill out the evaluation at the end of the meeting. You have a quiz about advanced directives. We'll do that in a few minutes. And I think that's, what else do you have on the right? Oh, and you have the slides. Everybody should have, I don't have all the slides that we'll show here, but you do have some. If you want to take notes in the margin or whatever, you've got more than half of the slides we'll be showing today. Okay, any questions so far? Pardon me? Jay Fleur has an announcement.
Yeah, just before we get started, I want you all to know that anytime you need to use the restroom, feel free to get up or refreshment. And it's right around behind this wall. There are 2 bathrooms.
Okay, and we'll be taking a break, a 5-10 minute break about it in the middle. There are a couple documents you don't have. One is additional resources. And for those of you who are coming March 10th, you will get that listing. It's about 7 pages. Or no, the additional resources, I forget, it's 4 or 5 pages of pointing you to more resources that deal with these issues. And the other one is called Considerations and Phrases. And that is 7 pages. And that's phrases that you might want to consider including in things like your advanced directives, your living will, and so on. And among those are, well, a new one I just learned. Even if you have specified no artificial hydration or nutrition, if you're being cared for, the staff will still try to spoon feed you. And you open your mouth as a reflex, even if you don't want the food. So if you don't want to be spoon-fed, you have to specify that, among other things. So it gets a little complicated. That's why we have all these things you might want to consider including. Who's here for the first time? Okay. Thank you. Let me know what you think. We will be showing a video as part of this demonstration. We recently remade it. The video we're showing is, what, 15 years old or more than that. And we do have a new version coming up. It should be ready in a couple of weeks. But we'll use this one today. And let me add this. I usually say this after the end of the video. But one thing that you might want to include in your advanced directives is something like this. I am not independently wealthy, yet I want to do all I can to ensure that your wishes are honored, or my wishes are honored. Therefore, please include in your financial will and advanced directives a phrase similar to this. It is my firm intention that I or my estate will pay for any expenses incurred in making sure that my healthcare wishes and advanced directives are honored. For example, ambulance transport to leave the hospital, attorney fees if court is involved or otherwise. So the whole situation of advance directives is they're more often than not, they are not honored. You don't get what you want. That's why we conduct these. It is slowly getting better, but slowly. Okay. Let me hear from maybe just 2 or 3 people. What, maybe particularly somebody who's here for the first time. What are your concerns? What brought you here today? Anybody? What motivated you to come to this? Anne?
I'm thinking of my 2 sons and what they just went through some very difficult times when their father died. We're divorced, and I don't want them to have to go through that kind of thing again, so I want to get all my ducks in a row, get everything lined up, and so that they'll have no questions. What would Mom want? I want it all very clear.
Good for you. Thank you. I'm sorry their father died. Not a good death, I presume? Yeah.
Awful. And it was awful. What made it worse was it was really awful afterwards with all the legal stuff and the paperwork, and it was a nightmare.
Yeah. The way we die in this country is not good. I have seen so many people die badly. Anybody else? Yes, sir.
I'm to dig that's in Zurich, Switzerland, and I sent a request in last year, and they wanted $6,699, and the doctor decided that I was, quote, depressed, and they didn't refund my money, so that's why I came to some other.
Oh, okay. Well, you may want to come to what we call, are you on my email list to get notices about our...
I don't know, I just recently...
Do you have email?
I do.
All right, make sure you get on my email list to receive notices about our meetings. You may want to come to our demonstration of the inert gas method.
Are you a member of that? Are you a member?
No, I don't think so.
Yeah, you don't have to be a member.
Come to the den?
No.
No, I don't mind being a member, I just usually show.
Oh, okay. Okay, anybody else? Today is about advocating for oneself or another to make sure you get the kind of medical treatment you want and don't get what you don't want. We do this because we with Final Exit Network believe it's important for you to have this information in a straightforward and thorough manner. Because otherwise you may have to find out the hard way. Because Americans do not regularly or comfortably talk about death and dying. And because having done this several times, this is our most well-received and appreciated program. And Final Exit Network does support having your wishes honored. And I may say this again later, but if push comes to shove and you end up going to court to have your wishes enforced, Final Exit Network may help you sue whoever is not complying. So we're fully behind making sure that you do the best to get the treatment you want. Final Exit Network, a national nonprofit, almost all volunteer organization that supports the right to die with dignity for mentally competent adults who are suffering with an irreversible illness or intractable pain. You do not have to be terminally ill necessarily. We hope you'll take away a good understanding of the importance of being and having a great advocate and the skills to be one. An increased realization that you can control what happens to you when in a medical institution. And an appreciation for the work of Final Exit Network. Some of the topics we'll cover are the various types of advance directives, how to use them, what makes a good advocate, why your wishes may not be honored, the critical importance of power of attorney for health care, and recourse you might have if your wishes are not being followed. In our discussion to follow, please feel free to challenge us on this presentation. Bring up new areas, questions for discussion, and I'm going to ask that you hold your comments till later, maybe right after the break or at the end, if you would. But we will have plenty of time for questions. Once you stop learning, you start dying. Okay, we're going to take a quiz. You have it in your handout. I want to give you a few minutes to execute that quiz.
I don't have
It is, would you give Melody one of those blue folders in that blue box? It is test your knowledge about advanced directives. For those of you who have the short form, which is this one, it's all on one page. Some of you have a larger form and it's on the front and the back. So please do go ahead and take that quiz. Okay, the first question was, what is your understanding of a DNR? What do you have? A, B, C, or D? Who has what? Tell me now. A. Anybody else? D. Anybody else? Okay. Okay, several different answers. Correct answer is D. A DNR order pertains only to CPR. The order requires health professionals not to intervene if a patient is found with no pulse or is not breathing. Okay. Question number 2. Is a DNR considered a legal order or a medical order?
Are the cameras on?
What was that?
Are the cameras on?
Yes. So what do you have? What was it?
medical.
Tell me A, B, C, or D. A, B, or C.
A.
A. Anybody else? A. Anybody have something other than A?
C.
B. Okay.
C.
C. Oh, we got them all. Okay. Correct answer. A. A DNR is considered a medical order. It typically is written and placed in a patient's chart by a physician. However, failing to follow a patient's DNR request could be used against doctors in court. Some institutions now use a new phrase for this, which I prefer, called AND instead of DNR. AND means allow natural death. I like that better than the DNR, but in any case, okay. The third question, what is a living will? A, B, C, or D? What do you have?
B.
C? Anybody else? A? Come on, don't be timid. D? D? Anybody else? Okay, the correct answer is B.
Oh.
I don't think I heard anybody say B. A living will generally directs health professionals to withdraw or withhold life-sustaining treatment if a patient is terminally ill or in a persistent vegetative state and can no longer communicate. Actually, you can word your living will to say that it takes effect now. I mean, you don't have to not be able to communicate and so on. And same thing to empower some. What is critical that you'll learn today is having a good advocate. Somebody who has your medical power of attorney for health care. And again, you can empower that person now. You don't have to be terminally ill. You don't have to wait till you can no longer communicate. Even though that's the way the Arizona form reads, you can change it. Okay. And by the way, a living will, the only document that has any teeth in it is empowering somebody to have power of attorney for health care. They then are as if you were speaking. They have full power over what is done or not done to you. All the rest of these, like a living will, it's merely expression of your wishes. It's good to have, but it ain't enough, and it's not legally binding. Yes?
To assign a medical power of attorney, do I need to have an attorney draw that up, or can I just write it down on my own?
You need to fill out the Arizona, all these forms are state specific. You need to fill out the Arizona form for that. You do not need an attorney to do that. As some documents on that, and I have reference to those in the handouts, where to get these forms. Again, we'll have them all next Saturday at the workshop. Some forms do ask that they be notarized or witnessed. I say do both. Get it notarized, get it witnessed. The more legitimate, the better. Now, having said that, it can't hurt to have an attorney review your documents and help you prepare those. And next Saturday, again, we will have an elder care lawyer present if you have any questions about them. But you don't have to have an attorney. Okay, so somebody else with a question? No? Okay, next question was, what is the proper term for the appointment of a person who can speak on a patient's behalf? What do you have? A, B, C, D, or E?
A.
E, A, pardon? A. Anybody else? Anything else? E, spokespersons for patients are referred to by various names depending on the state in which they live. Okay, question number 5, an advance directive must name a patient spokesperson. You have A or B there?
A.
A. Anybody else?
B.
B. Correct answer is B.
Really?
Yeah, you don't have to. Yeah, as far as I'm concerned, you have to. That's what's important, but you don't. It is not required. Some advance directives identify a person to speak on a patient's behalf, but the provision is not required.
Huh.
Okay, next question is number 6. One component of a living will is that the patient is, what do you have? A, B, C, or D? A. Anybody else?
B.
B. Anybody else? Okay, we're all wrong so far. The correct answer is C. The majority of living wills say not to treat a patient after the patient has, after the patient has entered into a terminal condition, despite sound medical treatment, or if the patient remains in a permanently unconscious state. A living will can be written to accept or refuse specific life-saving medical care during such an event, including mechanical respiration, antibiotics, or insertion of a feeding tube. Okay. What is necessary for a healthcare power of attorney to begin making healthcare choices for the patient? A, B, C, D, or E? What do you have?
C.
C, B, any others? What was that, E? B. Correct answer is C. The necessary requirements for a power of attorney to be activated depend on the jurisdiction. However, many states say 2 physicians first must determine that a patient is unable to communicate and direct his or her own medical care. Again, you can change that to empower somebody right away. So if you're snowbirds and you live in another state part of the year, you need to fill out those forms, not just rely on the Arizona forms. And lastly, when is an advance directive enacted? When is an advance directive enacted? What do you have? A, B, C, or D?
C.
C? Anybody other than C? Correct answer is C. Advance directives are activated based on the details within the document. The directives language should be read closely to be sure the patient's circumstances call for the order to become triggered and then followed. Okay. Thank you for indulging us in that quiz.
I have a question.
That's why we do this.
John, I have a question.
Yes.
Way back on 6. What about a patient who is unconscious and unable to make decisions for themselves but not terminally ill? Can the advocate not take a role at that point in time?
If the patient is, they have appointed somebody with power of attorney,
Yes.
and they're unconscious,
Yes.
the advocate speaks for that person, as if they are that person.
So They don't have to be terminally ill.
No, that's correct. They do not have to be terminally ill. You don't have to be unconscious. You could empower somebody sooner in that circumstance as well. But yes, it's as binding as if the patient were saying, get me the hell out of here, or whatever it is. Yes. Okay. And so I like to include this one. Thank you, Reverend. Your sermon has me super excited about protein. Okay, what nobody ever told you about advanced directives. Too often, they are ignored. They are not honored. And it's hard to get accurate data on this, although if you or anyone you know has had the experience of not having them honored, please let me know. Final Exit Network is compiling data on this, but it's hard to get data on this. People don't report it. But one study done by the Hastings Institute said as much as 70 to 80% of the time, your wishes are not honored in your living will and so on. So today you're going to learn how to make these documents work for you. I like to include this in many of our presentations just for the heck of it. 5 basic truths about life facing death. Everything changes and ends. Can you believe that even space and time will one day end? Everything changes and ends. Things do not always go according to plan. Life is not always fair. Pain is part of life. And people, believe it or not, are not loving and loyal all of the time. I'm not a pessimist, but these things do happen. I wish somebody had taught me this when I was in about 4th grade, so I didn't have to find out the hard way. You know? Whoever teaches people how to die teaches them how to live. Okay, the topic is death, and we will include information about some means of self-deliverance, hastening one's death. As I mentioned, the right to die. And by the way, there are only 2 methods that we do recommend. One is the inert gas method, and the second is stopping eating and drinking, which is the way most people in hospice care die these days. Those are the only 2. We don't recommend drugs or other methods for a number of reasons, and we go further into those in our demonstration of the inert gas class. Everything I do, everything we do is within the law. We provide information, freedom of speech. Please note, if anyone tells me they are about to take their life, I am bound to report that person as suicidal, a danger to yourself or others. Okay? Okay, do feel free to ask questions. If you don't want to ask it right now, write it down. If I don't know the answer, I'll find out the answer for you. That's my contact information, particularly you, sir. You might want to email me at johnwithfen@earthlink.net so that I can add you to our list about meetings, or call me at 520-235-5646.
Excuse me, that question on that page back there, where
Yes.
you're supposed to report if somebody tells you?
Oh, yeah.
Who do you report?
Well, I have to tell the police, but not in the circumstance of somebody where we do support hastening their death. If somebody is chronically suffering and chooses to hasten their death, that's a different story. Okay, yeah. And by the way, how many of you here know about exit guides? Exit guides. Okay, it's a little bit off the topic, but nonetheless, one of the great things that Final Exit Network provides, we never encourage anybody to hasten their death, but if you choose to do so, we provide exit guides, always 2, never just 1. They fly all over the country. It's our largest expense. It's free. You don't have to even be a member of Final Exit Network. And we do that because we don't think anybody should have to die alone. And although they cannot get the equipment for you, nor manipulate the equipment, they can be there for instruction as well as emotional support, so they can make sure you do it right if you have chosen to hasten your death. And we have a medical committee that screens people. You don't have to be terminally ill, but you do have to have something failing. They'll ask for some medical documentation. And once you're approved for the medical committee, the guides will tell you how you could get everything you need delivered right to your door. The nitrogen, the flow meter, the regulator, the tubing, and they'll instruct you as to how to proceed. I happen to be in favor of right to die, in case you haven't guessed that already. I regard death as a natural, rational, normal part of life. You know. Let me ask a little bit of who's here. Any physicians? Of course not. Doctors? You're a doctor, sir. What practice?
Family practice,
Oh, great.
now called quality care, no, general care, what is it called?
Integrative medicine, maybe? I don't know.
Primary.
Okay, family practice doctor, great. Any others? Any nurses? Any hospice workers or hospice volunteers? Any lawyers? Okay, all right. Any clergy? Anybody here terminally ill presently, if you care to let that be known? Okay. Another chance to ask what are your concerns. I did ask earlier what brought you here. Any particular concerns? Okay, in case you don't agree with the right to die, the right of somebody to hasten their death, being tolerant does not mean that I share another's belief, but it does mean that I acknowledge another's right to believe and obey his own conscience. Okay, it's important for you to know this. Most of us will die some kind of managed death, about 80% of us. And 80% of us will die in a hospital or a medical institution. You need not be terminally ill or even elderly to be protected by advance directives. Look at the case of Terry Schiavo. You remember that one? Terry Schiavo was 26. Karen Ann Quinlan, several years before that, another one that got a lot of notoriety, 21 years old. Nancy Cruzan, another one covered in the media, 24. And just a year or two ago, Brittany Maynard, who moved to Colorado to get a hastened death, was 29. So, as far as I'm concerned, everybody 18 or older needs to fill out these documents and get a good advocate. Health expenses are the nation's leading cause of personal bankruptcy, even with health insurance. Now, very seldom is money the reason that I want to hasten my death, cost. That's very seldom the primary reason, but it does enter into it. A lot of people would rather be able to leave something to their family, their charity, their children, rather than spend all that money on end-of-life care, which is very expensive. Most of us in this country, you are more likely to spend in the last 6 months of your life, in the last 6 months, you're going to spend more on health care than you have spent in your entire life up to that time. It's very costly. Last year, Medicare spent over $50 billion, on people not 6 months, who had not 6 months or less to live, but who had 3 months or less to live. That was not the prognosis, excuse me. They spent $50 billion on people who were within the last 3 months of their lives. $50 billion. Most of which did, I'm sure some of it did some good, but most of that did little or nothing to prolong their lives or improve the quality of their lives. Think what else we could do with $50 billion. Most U.S. medical schools do not require students to take a course on care of the dying. In fact, most physicians get about 1 hour of education having anything to do with death, and not just and not a credit hour, but a 60-minute hour. So it's kind of, that's part of the reason why this is uphill sometimes. Welcome. This is what you're up against. Dying is prohibited. This is Thanatos, the god of death. I am a thanatologist, thanatology being the study of death and death-related issues. It comes from the Greek Zeus and the gang. The god of death was Thanatos. His twin brother was Hypnos, the god of sleep. And sometimes when I tell people that, they say, oh, death. To me, it's not morbid. It's really about making the most of life. To take death seriously is to take life seriously. How will you face death? Everything can be taken from a man, but one thing, the last of the human freedoms, to choose one's attitude to any given set of circumstances, to choose one's way. Okay, we live in a massively death-denying culture, a death-phobic society. We don't talk about it. Partly because we don't know what to say, partly because we're afraid to bring up an unpleasant or uncomfortable subject. So I want you to do a little bit of, I know this sounds very elementary, but please bear with me. Repeat after me some D words. Everybody say death.
Death.
Dying.
Dying.
Dead.
Dead.
Yeah. I encourage you to use those words when talking about this subject. You know, so often in my book I've got, what do I have, Tim, maybe 200, 300 euphemisms that we use. What else do we say instead of that? Passed away. What?
Demise.
Demise.
Moving on.
Moving on.
Kick rocks.
What?
Kick bucket.
Kick the bucket, bought the farm.
Beamed up.
What?
Beamed up.
Beamed up. Yeah, beamed up. Gone to meet his maker, whatever. You know, there are hundreds of them. I encourage you to use the D word. Two of my favorite euphemisms. You all familiar with Sedona, the New Age capital of the cosmos? Well, in Sedona, you don't die. You have a celestial discharge. And my other favorite is the bureaucratic one. The patient didn't die. The patient merely suffered negative patient care outcome. Okay. This is why you need the directives, why you need a good advocate. You will probably be in a hospital. And this is not just for when you're dying, by the way. It's any time you're going to encounter a medical institution. You might be in pain. You might be in a nursing home. For psychological and social issues, responsive healthcare professionals, imperative for another directive, and so on. Let me elaborate on those. This is from Paul Kiernan, author of a book called Last Rites, Rescuing the End of Life from the Medical System. And Kiernan wrote, among other claims, many people who die in hospitals today suffer severe untreated pain. Now that has been getting better, although there is someone here today who is in chronic pain and they cannot touch it, which is horrible. But it's slowly getting better. But if you're one of the 5 to 7% whose pain cannot be treated, it's hell. It's hell. And the fear of recurring pain can be as disabling as the pain itself. Several years ago, this was worse, but residents were abused in 1/3 of U.S. nursing homes. 1/3. I saw recently in California, if you report a nursing home abuse to the authorities, it takes them 3 years to even get to it. You probably passed away and bought the farm by that time. You know? 3 years to wait to see if there's any compliance. Kieran says, we found that psychological and social issues were more common reasons for a patient saying they wanted to die, particularly concerned about being a burden to their family and existential issues about what would happen to them at the end of their life. In my book, I've got a listing of, I don't know, 30, 40 different existential issues. Again, money is seldom the primary cause. Even being terminally ill is not necessarily it. Most of the concerns are things like loss of quality of life, loss of autonomy, loss of dignity, unable to do the things I enjoy doing, and so on. Okay? Kiernan says, we found that healthcare professionals commonly did not respond to statements about wanting to die because they were worried they would say the wrong thing and further upset the patient, or because they were worried about professional and legal sanctions. If you're in the hospital and you tell the staff, oh, let me die, more likely than not, they're not going to take that seriously. Now, if your advocate is saying, you damn well better do that, that's a different story. But they're not. The whole system is geared to keep you alive, no matter what. And the doctor is nodding in agreement, I trust. Thank you, sir. Yeah. Kieran spent 3.5 years studying why so many Americans die bad deaths. And he sees at least 3 of what he calls imperatives behind the need for all adults to complete an advance directive that clearly states how they wish to be treated if they're unable to tell doctors, or to empower their advocate to tell doctors what they do or do not want. Number 1, to prevent avoidable suffering for the patient and the patient's survivors. An advance directive permits people to take control during the most vulnerable times of their lives and avoid unwanted, futile medical intervention that can cause anguish, not just for the patient, but for loved ones as well. Research data that Kiernan cited revealed that spouses are twice as likely to die soon after their partner's death if end-of-life care was not good. So it takes a toll on more than just the patient. Number 2, to protect caregivers. Doctors don't want to be flying in the dark, but they're so scared of being sued that they overtreat. And I may say this again later. By the way, one thing you can do, or your advocate, if you find the doctor is reluctant to enforce your wishes, you say something like this. Whether or not you even have a son-in-law to begin with, you say, you know, I think my son-in-law, the malpractice attorney, is starting to get a little concerned. They're scared to death of being sued. So threaten them with that if you have to. So here's a priest telling you how to lie. So they don't want to be flying. An advance directive protects doctors against litigious relatives who may threaten doctors with lawsuits if they fail to start or decide to discontinue life support, even when there is no chance for the patient to recover. And thirdly, to avoid bringing financial ruin to patients' families. If everyone had an advance directive and it were enforced, we would save billions and billions of dollars in healthcare costs and in ruin to families. Okay. So whose life is it anyway? Huh?
Your own.
Your own, right. It's your life and your death. That's what we're talking about. Now, you know, when considering all of this, you may want to consult healthcare professionals, your family, your friends, others. However, the only decision in the end that counts is yours. Only yours. It's your life and your death. Here's a little bit of sad poetry I wrote a number of years ago. The terminally ill in our society are subject to and vulnerable to the will of others. All too often, they are dehumanized and marginalized, drugged and plugged, medicalized and bureaucratized, underappreciated, needlessly emaciated, and overly sedated, alive but deprived, isolated and denigrated, neglected and rejected, and sometimes even adroitly exploited, usually financially exploited. It's slowly getting better, but not a lot. When given hypothetical situations involving imaginary patients with living wills, nearly 2/3 of 117 doctors surveyed said they would not follow the orders. They would not follow the directives. 2/3. They were most likely to diverge from the documents when confronted with family members with different views, or if there were hopeful prognosis for the patient. Well, it's not up to the doctor to decide, folks, no matter what the hell the prognosis is. Yeah, sure, you want to be informed, but you make your own informed decision. And by the way, if you have of course you want to have this conversation with your family. It's vitally important that you discuss this, what your wishes are, what your wishes would be, okay? But if you find you cannot win that family member over to your point of view, the only solution I have is this. It doesn't sound very compassionate, but my solution is don't tell them. Don't even let them know you're in the hospital. Somebody else can invite them to your funeral. And the reason I say that is because, again, if you have a family member, flies in from out of town, doesn't know what you wanted or disagrees with what you wanted, the doctor is scared to death that person's going to sue him. And that person will still be alive to sue. Now, whether they win or not is a different story, but the doctor still has to defend him or herself and so on. So, I wish I had a better answer, but if you have somebody whom you know disagrees, leave them out of the equation. You're only asking for trouble. Otherwise, okay?
With a patient advocate, I don't know how to word this.
Yeah, if you
Would
have...
they be suing the doctor or suing the patient advocate who made the decision?
Well, it could be either. If the advocate is not doing what the patient had instructed them to do, I assume that's the person is open to litigation. But the big thing is the doctors. Yeah, that they'd be suing, they may even be suing the medical institution, but they would be suing the physician. Yeah. Does that answer your question? Yeah. These findings are not surprising, said experts who study end-of-life issues. It's hard to predict what you want as medical care in advance. They never know what the situation will be. They're particularly complex and constantly changing. Again, you can never name everything, but you might want to get a hold of my list of 7 pages of considerations and phrases of things that you do want to include. In another study, researchers sent surveys to 250 doctors and asked them how they would handle 6 hypothetical situations involving seriously ill patients who were not capable about making decisions for their own care. In 65% of the cases, the doctors surveyed said they would not follow the advanced directive orders left by the patient. In difficult clinical situations, internists appeared to consider other factors, such as, again, prognosis, perceived quality of life, and the wishes of family or friends as more important than the directive. Guess what? They're not more important. Your decision is what's important. Yes, sir.
In my experience, that doctors consider their patient's death of their failure.
Yes, yes. Yeah, see, again, the whole system is geared to keep people alive. And doctors do sometimes consider death as a failure. And they haven't been trained to deal with it. And you know, gone are the days where you're personally close to your doctor as much as you used to be, but nevertheless, the doctors may start to decaffect, to detach from you. because they're about to have you die on them. Or they may do so because they think, well, rather than spending all my time with this person who is dying, I could be fixing 100 broken arms, you know, whatever the case may be. Jay Floor.
Could I ask you to just repeat a question when somebody is talking?
Okay, the last one was, who would they sue? And I'm saying it's primarily the doctor or the medical institution. Thank you. I will try. You all help me try to remember to repeat the question, okay? Sure, again, it's fine to consult your friends and family, physicians, other healthcare providers, and all that. But it's your decision. And after all, for all these reasons, isn't that why you're here today? Okay. Patients simply don't anticipate what might happen. This is from Dr. Howard Brody, bioethicist at Michigan State University. Often patients simply don't anticipate what might happen in the hospital room, or they issue vague directives. People say things like, no heroics. Well, what's heroic? What's not heroic? What does that mean? In some cases, patients may write directives ordering that they not be placed on ventilators, you know, the devices that help you breathe. But when the patient actually enters the hospital, doctors may violate the order because the patient only needed to be on a ventilator for a few days. Then it looks like the doctor is not following the patient's directive. But if you'd actually been able to talk to the patient and explain, the patient might well agree with that. Okay, let's try the ventilator for a couple of days. So what are people to do when they hope to control their care, when they cannot speak for themselves? Before I get to that part, if you discuss, if it's your wish to possibly hasten your death, unless you know where the medical provider stands already, do not bring it up directly. You want to discuss it in the third person. You want to say something like, you know, my friend Susan has been suffering terribly for many years, blah, 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 blah. And she is now considering hastening her death. What do you think? Because if you bring it up directly, you will be arrested against your will, put in a psychiatric institution for 3 days to a couple of weeks as being a danger to yourself or others. Okay? So unless you know where that person stands, bring it up in the third person. Okay? And you knew somebody here who had that happen, didn't you? That was a couple of weeks. Go ahead.
You want me to mention that?
And I know 2 women in Tucson who have had that happen to them.
Yes, we had someone actually here in Milagro, and she had diabetes type 1, which she's had her whole life, and had a pump on her body, and she was 75, and was struggling more and more with some of the care and symptoms of it. And she said she's ready, to herself, ready to die. So what she decided to do is get herself off the insulin, sir, right? And she took herself off. And and she said, well, I'll die that way. And somebody heard about that who was a doctor, and there was someone who was a nurse, and they called 911. And this woman ended up in the psychiatric ward in a hospital for 2 weeks before she was able to proceed.
So be careful. But again, I do encourage you to discuss what your wishes are as much as possible with your family and friends and so on. Okay, some doctors, this is called the principle of double effect. It is legal, it is ethical, Some physicians will invoke this. The doctrine of double effect is invoked to explain the permissibility of an action that causes a serious harm, such as the death of a human being, as a side effect of promoting some good end. So, let's say your doctor, you've had the discussion with your doctor. The doctor does agree with death with dignity, with the right to die. Well, that doctor may then give you enough pills to kill yourself, knowing full well that's what you're going to do with it. But he did not give them to you to kill yourself. He gave them to you to relieve your pain. That's the double effect. Likewise, although National Hospice is opposed to right to die. Hospice does not support right to die. However, again, some sufficiently compassionate hospice worker, nurse, may, in fact, if they know your wishes, agree with you, give you enough morphine to kill yourself. And then they'll say something, oh, but knowing full well that's what you're going to do, but they didn't give it to you to kill yourself. So they give you a load of morphine and they say, oh, now be careful, don't take too much, it could be trouble. You know, that's the double effect. Sometimes it happens. Okay, if you don't learn anything else today, legal precedent leading to modern views of end-of-life issues dates back to an 1891 Supreme Court ruling that people should have control over their own bodies. From that precedent grew an understanding that the people must understand and agree to medical treatment, and that a right of informed consent does not end when people become incapacitated. People have a right to refuse treatment. So you can always and everywhere say no. This, by the way, death without dignity, dressed as a clown with a flower pot on his head. He won the right to die without dignity. You or your advocate can always say no. You don't even have to, and most of us would rather die at home than in the hospital. You don't even have to stay in the hospital. Now, if you leave against the doctor's wishes, you may have to sign, or your advocate sign a release saying, yes, I'm leaving against the doctor's recommendation, but you don't even have to stay there. So you always and everywhere can say no.
But what about those instances, as in the recent one, where the legislature got involved?
What about those instances, as in the recent one, where the legislator got involved? Damn the legislature. You're talking about the Terry Schiavo, where the president even got into it? Yeah. It's not up to the legislature, it's not up to the president, it's only up to you. But what's critical, again, is having somebody with durable medical power of attorney, and if you can't speak for yourself. And the courts will uphold that. The statutes are very clear. And I'll get to this when I talk about what recourse you might have if your wishes are not being followed. But the last resort is you go to court. And the court will honor what the person with medical power of attorney has to say. They're very clear about that. And it's none of the legislature's damn business. Okay? All right, here's the self-euthanasia kit. Would you also like to purchase the extended warranty? Actually, I've only been with about a half a dozen people who have used the inert gas method, but I have a friend who's been with over 200, and there's never been a problem. So, all right, what we do is we provide support, information, and education. These are some of the programs we have here in Arizona. We've had Derek Humphrey, who wrote the book Final Exit. We've had Faye Gersh, president of the World Federation of Right to Die Societies, and other national speakers here. We do an overview of right to die in the U.S. and elsewhere. And by the way, if you're a member of a church, a civic group, community, any kind of community, I hope you'll consider having me go there and give about an hour or 40-minute presentation about the right to die, what's involved, and what we do, what we don't do, and educate the community about it. You know, Final Exit Network is a tiny organization. In this whole country of what, 335 million people, we have about 3,000 members. Not a lot, right? Of course, many of them die on us, which is extremely inconsiderate, but we're tiny. Our budget is less than $500,000 a year, most of which is spent on either legal defense or flying exit guides all over the country. So the more we can get the word out, the better. That's why I ask you to take membership brochures and newsletters and distribute them. Invite me to talk to your group, whatever that group might be. Okay, we do I already mentioned the demonstration of the inert gas method. This one, advocacy training. Another one that we started, I think, last year was called, so we do this one about every 2 months. It's called Small Group Social Gatherings. Some finger food, cookies, cheese and dip, cheese and crackers, shrimp and dip, some munchies. And then we provide a list of several topics they may want to discuss. And we have 2 sessions wherein they discuss those death-related issues among themselves and then briefly report back to the whole group. Those have proved to be very popular, those small group social gatherings. And it's a chance to get together with like-minded people, you know, who agree with what we're up to. Okay, if you're progressive and you believe your body is your own, Final Exit Network will help protect your rights. If you're conservative and don't want government dictating what dying process you must follow, Final Exit Network will help protect your rights. And if you're middle of the road and are just seeking information, Final Exit Network will help protect your rights. At home, I have a large button just like that, yellow with red writing on it. It's about 6 times the size of this one, saying just that. Let me die like a dog. Isaac Asimov said this about Derek's book, Final Exit. No decent human being would allow an animal to suffer without putting it out of its misery. It is only to human beings that human beings are so cruel as to allow them to live on in pain and hopelessness in living death without moving a muscle to help them. It is against such attitudes that this book fights. The book Final Exit and the book How to Get the Death You Want. You want to be careful with the DNR. Here's a fellow just asleep at his desk. Do not resuscitate. The DNR is a last resort, okay? You really want to be careful with that. I did see recently, I didn't think this used to not be true, and it may still not be true in many cases, but I did see recently where the person did not have the adequate documents and so on. And by the way, in Arizona, it has to be on the orange state form, signed by a doctor and so on. But this person had DNR, either, I forget whether it was tattooed on their head or on their chest, and they honored it because of that. Usually, though, that's not enough. You have to have the document. But you want to be careful. It's the last resort. You know, you could have a stroke, a heart attack, or whatever, and be brought back and be fine for many, many years. So be careful with that one. These are the different Arizona advance directives. Mental health power of attorney, letter to my agent, letter to my doctor, living will, DNR, or as I mentioned earlier, AND, allow natural death. Sectarian health directive, okay, that one is, you know, we have Catholic hospitals here who do not support right to die. And if you find that the hospital is not honoring your wishes, this one says, you must transfer me to a hospital that will. Okay? Directions for disposal of the body at death. Now, any other power of attorney, whether it's medical power of attorney, financial power of attorney, they go away the split second you die. So you have to name somebody, well, you don't have to, but if you want to have somebody have control over your body after you have died, to facilitate the funeral or cremation or green burial or whatever you have planned, you need to name that person separately. Other documents, post. Post is in at least 28 states now, and that stands for Physician Order for Life-Sustaining Treatment. It is not yet universal in Arizona. The good thing about that is, although it says life-sustaining treatment, you can designate in there what you do not want, right? The good thing about it is it's the only other document that has teeth in it. It's a doctor's order. Okay, it's the doc, and we all know the doctor is God, right? Okay. So it's a doctor's order, and it can follow you from home to the nursing home to the hospital, wherever the case may be. Unfortunately, it's not throughout Arizona yet. Again, most importantly, somebody who has power of attorney for health care for you. Much more important than your living will. The law is not sufficient. Have an advocate with you. Yeah, I suggest having your advocate with you whenever you visit the doctor or enter a medical institution. Some medical ethicists, such as Robin Shapiro, the director of Bioethics Center at the Medical College of Wisconsin, recommended that guardians be appointed to make sure the wishes of patients are followed. This is particularly important. Particularly important because the law does not always provide enough teeth to guarantee that the doctors will follow your wishes, your orders. I and ABC News, what, 6 years ago, suggest having an advocate with you whenever visiting a doctor or a medical institution. Here's why. Here's a person dressed in one of those deliberately demeaning hospital gowns that leaves your butt flapping in the wind, right? Medical studies indicate most people suffer a 68% hearing loss when naked. Well, what that means is, let's say you do go to the doctor, and the doctor says, well, John, we've run all the tests. I'm sorry to tell you, I have very bad news for you. You do, in fact, have cancer. In fact, it's a particularly virulent, aggressive form of cancer. And then the doctor goes on to say, we can do this, we can do that, and so on. Well, guess what? I haven't heard a damn thing after I got that diagnosis, okay? So you want somebody with you to help you absorb the information given to you, and you want to get it in plain English, not all medical speak, and to ask the right questions. And again, there are lists of questions in your handout materials. So it can be very important to have somebody with you. Advocate. To make a difference in someone's life, you don't have to be wise, rich, or beautiful. You just have to be there when they need you. This is one of my favorite phrases. Don't just do something, stand there. You know, just being with somebody can be very supportive and comforting. Now we should be getting close to the break. I'm going to back up and, what time is it now?
10:30, 10:20.
Oh, okay, well, we're going to keep going. Okay. Despite laws requiring hospitals to make advance directives available to patients, routinely end-of-life wishes are ignored. Have yours with you, or have your advocate have them with you when you enter the hospital. And last year, I went to a number of hospitals, and doctors' offices should also have these documents for you. And guess what? They're required by law to make these available. Guess what? About half of them didn't have them. The other half had incomplete documents. John?
The ones available, in my experience, the ones available from hospitals don't give you much choice. They're not good. I'm an advocate for someone, and he got one from the hospital. It was just a worthless piece of paper.
Okay, the comment was that the documents they got from the hospital were virtually worthless, and that's why we're teaching you this today, yeah. Sorry that was the case, John.
There's one
Yeah.
online from the Attorney General that's very good.
Yeah. You can get them from the Secretary of State or the Attorney General's office. They're all in your handouts. Yeah, as I said, half the hospitals had incomplete packets and so on. The other half had nothing. Doctors' offices as well. Okay, we've mentioned this already, but all too often the doctors and hospitals equate death with failure. For reasons of culture, arrogance, or baseless fear of a lawsuit, they instinctively act to delay death as long as possible, even when the patient protests. And there's another factor that plays into failure to respect advance directives: money, right? Reimbursement policies promote extensive and expensive tests and procedures, often delivered despite patients' wishes and without informing them. And these days, the doctor may run tests on you without even asking, and of course bill you for it. I happen to think managed care is one of the worst things that ever happened to medicine, but the whole thing is driven by money. Okay, you can always say no. The primary reason that people disagree with death with dignity or right to die, and the reason that some people will not honor your directives is religious beliefs. Okay, if you're in the hospital and the charge nurse or your immediate care nurse feels called by God to keep you alive no matter what, you're in trouble. Your wishes are ignored may depend on your caregiver. As I mentioned, religious beliefs and so on. If you're terminally ill, the doctor is faced with losing you and may want to deal with others with a better prognosis instead. Another reason they're not honored is the pain of losing you, so to speak. But why they're not honored does not matter as much as why they must be honored. It's your life, your death. One can always say no. You can leave the hospital even, as I mentioned. And by the way, if you leave the hospital, Medicare will still pay the bills. Now, whether your private insurance will pay the bills if you leave the hospital against doctor's orders, you need to check with your insurer. But Medicare will. There are two obvious reasons why a doctor might not follow an advance directive, said Howard Brody, bioethicist at Michigan State University. Reason one is that the doctor is a jerk and is practicing unethical medicine. There are a few of those. The second reason is that the advance directive is unfollowable. Again, something like no heroics. Also, your wishes and wants, and even the procedures may change. Medical staff are trained to keep you going no matter what, but you may have written your directives 10 years ago, and they're able to do things now they were not able to do then that you would want. I already mentioned the profit motive, threat of litigation. I already told you about my son-in-law, the malpractice attorney. Be aware of this: carelessness and mistakes and miscommunication. It has been determined that within hospitals, those are now the third leading cause of death in this whole country. One of the third leading causes of death is medical errors, mistakes, miscommunication. Happens all the time. It happens probably more often than not. Another one to be aware of is hospital-borne infections. That too, and by the way, the first one that eventuates, again, not all of this gets reported, so the number may be even larger, but it's about 500,000 people die a year because of preventable medical mistakes and errors. Same thing with hospital-borne infections. About 500,000 people a year, a leading cause of death. So one of the solutions to that is you or your advocate should ask anybody entering your hospital room to wash their hands. Now, you know, they have these antibacterial dispensers at the door or next to your bed or whatever. Those are not nearly as effective as washing your hands the right way. Who knows how to wash your hands the right way? Yeah, warm soap and water while you sing Happy Birthday twice. Yeah, a good wash is much more effective than those squeeze the bottle, do this, and hope you're germ-free. So you or your advocate you may feel awkward asking them to do that, but say, hey, I am aware that hospital-borne infections are a serious problem. Would you please wash your hands? Now here's a person hooked up to artificial heart, artificial lungs, artificial liver, artificial stomach, artificial blood, holding up a sign saying, please let me die. And the response is, what? And play God? You know, the attitude is, only God gave life. Only God can take it away. That's not what I happen to think she believes. God, that is. But I maintain that withholding treatment or even supporting someone's right to die is not playing God. Playing God is to abrogate the freedom God gave us to make our own informed decisions. I have a friend who teaches himself, what do you call, biofeedback? Is that what you call it? Yeah. And he's trained himself so that if he's barely able to speak at all, let's say you're in the hospital, you're suffering, you're barely conscious, if you can't say anything else, say 10, 10, 10. Why? Because they always ask you, how serious is your pain on a scale of 1 to 10? So if you're just saying 10, maybe you'll get some attention. My father was a hospital administrator. He was executive director of the hospital. And he was from England. He was British. He was very quiet, soft-spoken guy. And one day at the dinner table he said, you know, John, I don't run the hospital. The board of directors don't run the hospital. The doctors don't run the hospital. They may think they do, but they don't run the hospital. The nurses run the hospital. Okay? So it's your immediate caregiver who can make a big difference. I like this quote. Too often, medical care is confused with love. They're not the same. Sometimes the best thing you can do for someone you love is to stop the medical care. Here are the 3 most frequently mentioned end-of-life concerns. And this has been true for the last several years. They may vary from year to year by about 0.5% or something, but they're pretty consistent. Loss of autonomy, 93.5%. Decreasing ability to participate in activities that make life enjoyable, 92.2%. Loss of dignity, 78%. most of us want a peaceful death. Only about 15% of us will be achieving that. Be aware of the boundary between living with versus dying from. Only you can determine what you want to endure, how much treatment, how much suffering, which and how many procedures, and so on. Death is timed in hospitals. The hospital routine is not based on your needs, it's based on the needs of the staff. So know how to advocate there or avoid being there. The best way to manage terminal hospitalization is not to have one. Understand and reframe engagement in heroic activity. Ponder a few things about who owns and directs our dying. The hospital, by the way, may have a secret word or code. These HIPAA laws, which I think are overkill. Some of them are ridiculous. I know my father lived to 96, died a peaceful death in the end. I was with him. But when he was 94 or 5, one of his still few surviving old friends, elderly friend, was in the hospital. They wouldn't even tell him he was there, let alone how he was doing. This is the hospital he used to run. But oh no, privacy of information, So when you enter the hospital, you sure want to name who you want to document, who can have access to your information. But they may also have a secret word or code. So if somebody calls in and doesn't say, you have to say A, B, C, or D in order for them to release the information. Okay, I already mentioned washing your hands, having the staff wash their hands. And by the way, these hospital-borne infections, they may take a week or two to manifest themselves, even after you've left the hospital. Being a patient is to be acted upon. You're feeling pretty puny in the first place, or you wouldn't be in a hospital, right? And so you may not feel like asking somebody to wash their hands, or you won't feel as assertive in having your wishes honored, and so on. To be a patient is a rather passive state. They're always coming in and poking you and probing you and doing this and that to you. Again, that's why you need the advocate. There are terms for these. Relating to a disorder induced by the treatment itself. Causes include chance, medical error, and negligence. The term is iatrogenic. That's the mistakes and errors that are so prevalent. And infections that are a result of treatment in a hospital or healthcare service unit. Infections are considered nosocomial if they first appear 48 hours or more after hospital admission or within 30 days after discharge. The term for those is nosocomial. CBS News in January of 2012 reported that in one study, only 14%, 14% of hospital injuries were reported. So again, this data is probably not high enough, not sufficient. The number of patients who die each year from hospital injuries is equivalent to 17 fully loaded jumbo jets crashing every week. Bless you again. 17 jumbo jets crashing every week. Well, if that were happening, we'd sure as hell be doing something about it. As at least one healthcare associated infection and antibiotic resistant organisms cause an important proportion of those. No one should get sick when they're trying to get well. That was the CDC about a year and a half ago.
When do you want to take your break, John?
It's coming up.
Bear with me. treating the patient. The word treat comes from the Latin root word tractare, which means to drag or draw or pull. And Latin patiens means one who suffers. So to be, I already said, it's a rather passive, debilitating condition to be in the hospital, but it means you're a passive long-term sufferer. Red flags during hospitalizations. Hospitals don't provide care. They provide bodily repair services under the direction of independent physicians, scientists, and nurses, monitored on some schedule. Typical medical communication during hospitalization results in confusion, shock, and harm to patients and families, obfuscating lapses in judgment and hiding medical errors. And you may be dealing with many doctors, not just one. That is typical, not occasional, medical communication. Shock, harm, lapses in judgment, hiding errors, and so on. Resuscitation matters are tricky no matter what the advanced directives say, because healthcare workers believe their main imperative is to keep you alive. And again, it may be good temporarily. Misdiagnosis. Medicine is not the exact science that we wish it were, and sometimes we think it is. NBC News, September of 2015, reported from the National Academies of Sciences, Engineering, and Medicine, misdiagnosis contributed to 1 in 10 deaths. 1 in 20 patients are misdiagnosed each year. So you need to ask for the tests and how to understand the results. A recent survey indicated that only 48% of patients said they were always involved in decisions about their treatment. Less than half. 55% of physicians have described a more positive prognosis than warranted. Okay? They're sugarcoating the prognosis. I, for one, would rather get the truth. 71% of doctors and 81% of patients believe communication impacts patient outcome. And of course it does. Doctor behavior, 55% of doctors said that in the last year they had been more positive about a patient's prognosis than his medical history warranted. And get this, 10% said they had told the patients something that was not true. 10% flat out lied to their patients, or admitted it. Maybe more than 10% did. 10% admitted doing so. About a third of doctors said they did not completely agree that they should disclose medical errors to patients. And 40% said they did not feel the need to disclose financial ties to drug or device companies. The doctor may order a bazillion lab tests. Guess who owns the lab? No, they didn't have to tell you that, I don't think. The Harvard School of Public Health reported in July of 2016 nearly 1 in 3 Medicare recipients had major surgery in the last year of life. 1 in 5 in the last month of life. 1 in 10 had major surgery in the last week of life. While 9 in 10 doctors said they would reject aggressive treatment at the end of their own lives. Doctors die much better than we do. They know better. Okay? And guess what? Surgeons want to do surgery. So of course, by all means, always get a second opinion. In fact, for years, I have maintained that you don't need a doctor to die. Better to get hurt by the truth than comforted with a lie. Am I dying? A recent study, only 11% of doctors said they personally spoke with their patients about the possibility of death, even though the doctor knew the patient was dying. Only 11% talked with their patients about that. There's a sign on the wall saying, "We can, therefore we will." And the patient is hooked up to all kinds of medical devices and whatnot. It wasn't what he wanted, but it does reflect our respect for the dignity of life. Dignity of life, we want to keep you alive. Okay, now the asked for break has arrived.
40 years, 38 years.
Wow.
The first 8 of which I was in a small town with a group of family physicians, family doctors, as we were called then. In a town of about 10,000, we had about 9 or 10 deaths a year. And every time we knew someone had a terminal event or a diagnosis or was going to die, all 4 doctors in my group would get together and discuss the patient and what we told them or did not tell them. And we would agree. There was myself, a Protestant, had a Jewish partner, a Catholic partner, and a Native American partner. And we would talk about the patient's condition and did we tell them what was in store or not. And many times we didn't tell the patient. I think it was only in like 77 or 78 the first time we told a female patient before her husband that she had terminal breast cancer. And we discussed it and we said, "Ms. Smith is smarter than her husband, let's tell her first." And that was a first, because the consensus was if you told the wrong person in the family first, it was going to destroy the family. This wife is a dingbat, she can't write a check, she doesn't know this and that, her kids are into drugs. Let's tell the husband first and ask him when to tell her or what to tell her. Now that to me sounds like a little bit of maybe early advocacy that we didn't realize. But everything else John has said this morning is absolutely true. Hospitals are wonderful places to get sick in, so try to stay out of them. The concept of a hospital is running your care is like giving your care to a complete stranger, as far as I'm concerned. And iatrogenic things that are caused in hospitals, if anything, are on the rise. So let your advocate or your wife or your husband tell you or be with you when you get any medical advice. And thank you for the floor, John.
Thank you, Sam. Okay, we're going to watch a video. As I mentioned, this is very, very old. We hope to have the new one within a couple of weeks. Hello, I'm John Abraham, and I serve as the Arizona affiliate leader of Final Exit Network. There are many cases where the wishes of the patient are not followed by the doctor, the hospital, or hospice helpers. Having an effective advocate who is your legal medical power of attorney can make a big difference in getting you the medical care you want and in not getting treatments and tests that you do not want. What is an advocate and what does he or she do? In this video, there are 4 scenarios, and in each case, the advocate plays a critical role. We'll call the advocate Andy. Throughout the video, you will see the advocate be assertive in dealing with doctors and family members to demonstrate how to get the patient's wishes honored.
Before we start, let's see what makes a good advocate. We will consider character traits and behaviors. Among the character traits, being perceptive and a good observer. Another is the ability to be empathetic and compassionate, to see through the other's eyes. And finally, having assertiveness, chutzpah, persistence, even being pushy at times, but not aggressive. The ability to set limits, such as time to say goodbye, time perhaps even to find another doctor, and do whatever it takes. With the behaviors, it is important to ask and listen carefully. Don't hesitate to ask questions of the family, nurses, and doctors. Ask about prognosis, alternative treatments, how long to live, pain control, and so on. Be prepared, know the patient well, and review the living will and advance directives. Stand back to get the broader picture. For example, what is the family culture like, or their religion? How might you talk to death-phobic family members about imminent death? And finally, act strategically. For example, don't just blurt things out. Think through your goal, figure out how you plan to achieve it, and diplomatically stay with your goal.
Hello, I'm Callie Hutchison, your narrator for this imaginative play which has been created by John Abraham, Cheryl Reyes, and Tim and J. Fleur Lohman. This will be a play in 4 important acts. This role-playing has been conceived as a fresh way to teach all people how to be better advocates for their wives, their husbands, their loved ones, and what to look for in advocates if they have to make this long journey themselves. You will want to model yourself after Andy Advocate. He's the one that you can learn from. In all the scenarios, Andy Advocate is there to help Patricia Patient and to enforce her living will and is her durable power of attorney. Patricia did not want to be connected to a batch of tubes to have her life extended unnecessarily, and Andy Advocate does his best to carry out Patricia's wishes. In each scene, Patricia Patient is 82 years old and in a terminal condition. Her husband died 8 years ago, a long, hard, painful death in which she saw him hooked up to machines in a nursing home for over a year. Patricia was aware of this, but she shielded the rest of her family from the information until he died. She now has Alzheimer's disease, has had it for about 5 years, and is getting steadily worse. She's been suffering from congestive heart disease, and on top of that, she recently had a massive stroke. The stroke has rendered her speech unintelligible. She is incompetent to make a verbal decision. She can sit up and sometimes appears to understand verbal communication, but she's been put on life support recently and has no chance for recovery. In all 4 scenes, Patricia Patient is Frank Family's sister, and because Andy Advocate lives here in town, Patricia Patient has made him her good friend, her advocate, her surrogate, her proxy, and her legal agent with the power of attorney for health care. This video is intended to raise a number of interesting issues, and when it is finished, we hope that you have many things to bring to the discussion. The scenes are not related to each other. What changes in each scene are some of the actors' intentions. After the play, we want your feedback or true life experiences that may be helpful. Okay, let's begin. Here we are in a hospital somewhere in Arizona. The doctor, the advocate, and the family are in agreement regarding the patient's wishes as suggested in the living will.
Hi Patricia, it's Andy. I don't know if you can hear me, but I'm here with Dr. Dorothy again. And your brother Frank, he's arrived. We're here to spend the day with you.
Actually, I don't think I know you.
Frank Family. I'm in from Minneapolis. Yeah.
I just wanted to bring everyone up to date. I've been treating Patricia for a couple of weeks now. I'm the ICU doctor. And while I've been meeting fairly regularly with Andy Advocate, I knew you were going to be here, so it always helps to have some input. Some of this you may know. Patricia's been suffering from Alzheimer's for about 5 years now. She also has a long-standing congestive heart disease condition, which you know is progressive. And now she's just suffered a stroke, which was sort of the crowning blow. Now things are looking not good.
Yeah, I can see that. I haven't seen her in almost 2 years. I can see the strokes affected her pretty badly.
Were you aware that Mr. Advocate has been helping out?
Yes, I know all about her living will and the fact that she made Andy her medical power of attorney, and she didn't want to be hooked up to all these machines.
I met with specialists in Alzheimer's and congestive heart disease, and although strokes are treatable, when you compound it with her other health issues, all the doctors reached a consensus. So, when you two are in agreement, we're comfortable with that.
Yeah. Well, Patricia's always said she didn't want to go like Mom did. Mom held on for a long time, and Patricia didn't want to put me through that, so I totally support her wishes.
Yeah, and you know, she's had that feeling for years.
Yes, it's my understanding that you and Patricia have been in communication.
Oh yeah, we go back almost 30 years, and for the last 10, 11 years, she's made it really clear she doesn't want to stay in this condition.
The procedure is that when you are ready, you can call for me and I'll supervise the disconnecting of the machines. We'll give you as much time as you need with Patricia. Mr. Advocate and I feel that you should have some alone time.
Yes, that would be very nice, thank you. I haven't seen her in quite some time, and I'd really like to spend some time with her, if that's okay.
You can call for me whenever you're ready.
Doctor, when the time comes, who actually turns off the machines?
I'm actually going to be the one doing that.
Okay.
As you know, the timing is up to you.
Today would be fine. Just give me to the end of the day, all right?
All right. Well, Patricia, we're going to leave now. Your brother Frank's going to stay with you for a bit, but I got to go. Bye-bye for now. We love you.
Now, in Act 2, the situation has changed. The Advocate and Frank family are prepared to honor Patricia and her living will, but the doctor has a different view.
Hey, Patricia. It's Andy again. I'm here with Dr. Dorothy, and your brother Frank is here too. He came in from out of town. We're here to spend the day with you.
Yeah, I think it's time.
It's time.
Hi, I'm Dr. Dorothy. Mr. Advocate, you and I have obviously been talking for a while now.
Yeah, I'm Frank family, Patricia's brother. I just flew in from Minneapolis.
Doctor. Yeah, so you've heard about her stroke.
Yes, I know all about it, and I know about her living will and her wishes to not be hooked up to all these machines.
Yeah, we both feel this way. As you know, she's appointed me the power to make this decision for her, and she can't make it herself right now.
I understand you're her advocate, and I'm glad the two of you have reached a consensus at this time, but I think it's premature right now. Look at her condition separately. She's had Alzheimer's for a while, but Alzheimer's, especially the level she has it, isn't immediately terminal. She'd be fully functional if she had Alzheimer's and nothing else. Her congestive heart disease is progressive, but it's not at the point yet where I would call it end stage. And strokes. We've been able to do miracles with strokes. I've already contacted rehab, and I think we can get her sitting up again, and we can get her eating on her own, and we can restore her speech.
That is all well and good, but this is not what she wanted for the end of her life.
No, not at all. Not at all.
Well, the doctor is the boss here. I understand that she has a living will, but...
You may be the doctor, but you are not the boss here.
I'm the boss, because I have her legal power of attorney, and she's given me this power to make this decision at this time.
And when we've reached the point where that's appropriate, I'll be more than happy to assist you.
But we feel we are at that point.
Look, we're obviously at an impasse here. What's our recourse?
Well, I'm the one who disconnects. I'm the ICU doctor, and I will make that decision when I think it's appropriate. It's okay if you want to talk to other doctors in the administration, but I think they'll back me up with a little more time here so we can work with her.
Yeah, well, I think we'll do that. We'll talk to another doctor.
How much time do you envision?
It might be a week, it might be 2 months.
So you'd let her suffer for another week? For another 2 months?
I don't see that she's suffering.
All right, well, we will deal with another physician. We'll talk to the administration. We'll go to court if we have to. But we're going to see to it that her life's over.
That's your right. Okay.
All right, well...
But I'm on record as stating that I do not support this.
All right, we will deal with another physician then.
All right.
Okay.
Okay. In Act 3, we have a very different situation. The advocate wishes to carry out the basic wishes, and the doctor is supportive, but Frank family is opposed.
Hi, Patricia. It's Andy, your friend. I'm here with Dr. Dorothy again. And your brother Frank flew in. He's here to spend the day with you, too.
Hey, Pat. It's good to see you. I haven't seen her in so long.
How long has it been?
2 years or so. We don't get to talk very often, so.
And you flew in?
Yeah, this morning from Minneapolis.
I'm so glad you could be here today.
Thanks.
Hi, I'm Dr. Dorothy. Thank you.
Thank you.
It's good to see you. It's good that you're here too.
Yeah. Well, she's looking good.
Well, we here at the hospital try to keep our patients as comfortable as possible. But as you probably know, she's had Alzheimer's for a while now. And she's in bad physical shape with her congestive heart disease. And, well, we're really reaching the end stages with that.
Wait, Alzheimer's isn't terminal, is it?
Actually, Alzheimer's has been determined to be a terminal disease. With the other condition, and now with the stroke, again, if it were only the stroke, I think there are things we could do. But my understanding is that having read her living will and talking to Mr. Advocate, I feel comfortable at this point honoring her living will.
I've shown you, Frank. She's expressed this point of view for more than 10 years now. She doesn't want to remain in this kind of situation.
Look, I hear you. I do, but I haven't seen her in so long, and we don't talk on the phone that often. I really need to spend a week or two with her.
We're comfortable giving you some time with her.
Yeah, but a week or two is not doable. I mean, I understand your predicament, but I hope you can say what you have to say to her within the next day or two.
No.
Possibly tomorrow morning, but there's no way I'm going to let her suffer.
I believe the family's got some sort of status in this situation.
Well, actually, I have precedence over the family.
Is that right?
In Arizona, the statutes do honor whoever the agent is named on the POA.
You're saying the family's got no say in this at all?
If you feel that her living will doesn't express your wishes or you have a problem with this, unfortunately, legally, I have to defer to Mr. Advocate because the hospital doesn't want to create a conflict here.
Well, doctor, she's got no one else to represent her. I've known her for over 30 years.
Look, I'm not saying she has to live forever. Nobody does that, but she's got to be good for at least another week or two.
She has never indicated anything close to wanting to be in this condition for a week or two. And I feel obligated. I appreciate your predicament. But I really hope you can say what you have to say to her in the next day or two.
I want to speak to the hospital administrator.
And I want to take measures necessary to honor her wishes.
That's your right, Mr. Family. But let me just ask, when you say 2 weeks, that puts me into a dilemma. When you talk to the administration, what are you talking about? Should we bring in rehab? Do you want her revived? Do you want us to take all the extra measures?
Look, I think it bears saying here. Patricia is a God-fearing woman. She reads her Bible every single day. And what you're doing here, taking her life, this is God's will, God's work. And I don't think this is what she'd want at all.
Well, what I'm doing is Patricia's work. God gave her a mind to think with. And she has thought about this repeatedly and consistently for years. And I feel obligated to honor her wishes. That's all I'm doing here. Obviously, she can't make her own decision now. She's trusted me to do this at this time. And it's not easy for me either to say goodbye to my friend Patricia, Frank. What I'm going to do is what she's wanted me to do. And we're not talking rehab here. The time has come.
Well, I'm going to go speak to the hospital administration, and when I come back, I'd appreciate it if you were gone so I could spend some time with her.
Okay. I'm sorry, Mr. Advocate. My hands are tied.
I understand. It's just, I'm committed to honoring her wishes. I'm going to do what I can.
Thank you.
Okay.
Now the situation changes again. In this scene, both the doctor and the family are opposed to turning off the machines, but the advocate insists on carrying out the patient's wishes. I frankly have been at odds with Mr. Advocate. I think it's premature. She has a number of disabling conditions, but they're all treatable. We think we can buy her some more time, and I've already called in rehab. I think there are things we can do for the stroke she suffered. I'm glad that you came in, actually, because I think that you, as family, should have a say.
But you do agree she's terminally ill.
Terminal, but not today.
Not today. Not tomorrow. Not next week. Not next month. But what's the point in having her lie here like this?
There's a great deal we can still do.
Yeah, her color's good. And you said the last time you took a scan that she still had brain activity.
Absolutely. Absolutely.
No.
She isn't as responsive as she was before, but again, there's still a great deal we can do.
Good. Good.
I mean, she has congestive heart disease, but we have medications for that, and she's comfortable here at the hospital.
No. She has never wanted to linger in this condition. She's never wanted to be medicalized, drugged, and plugged. She's told us repeatedly in the papers I've shown you before. She signed them every year for 10 years, indicating exactly what she wants to have happen should she be in this condition.
Well, you're talking about pulling the plug here. And as I see it, and I think Patricia sees it, you're doing God's work here. She's a Bible-fearing woman. And I don't think this is the way she'd want it at all.
Well, we just plain disagree. I've known her for over 30 years, and I've spent much more time with her than you have. And we've talked about this consistently and repeatedly. And I'm not doing God's work here. I'm doing Patricia's work. She's here. She's helpless. And she has no one to represent her and get her out of this condition, which is what she's clearly indicated she wants.
Let me remind you, Mr. Advocate, that nobody does anything without my involvement. And I feel very strongly that, yes, we do honor living wills at the hospital. I support them in certain circumstances, but in her case, it's plain. It's just too soon. You do not have my agreement in disconnecting her.
Well, that's just too bad, because it's my conviction that it's not too soon. And moreover, it's my conviction that it's Patricia's conviction.
Well, I'm going to go talk to my lawyer, and I'll be back.
I'm here to represent her. And I'm very clear on this. This is not what she would want. You're fired.
I've been to court a number of times, and let me tell you, you're not going to get anywhere without a medical opinion.
I'll get another medical opinion. And I will take this to court. I'm sure they'll hear it as an emergency case. And I'll see you after that. And I'm going to have the court rule that it's okay to disconnect her.
Well, they'll be listening to Mr. Family as well.
I hope they do. I hope they listen to everybody. But especially, I hope they listen to Patricia. I'm going to go call her lawyer. I'm going to get a hearing set up as soon as possible to have her disconnected from this life support.
This is John Abraham again. We hope you have found this helpful. I hope it helps you and your group to discuss these issues with your family and friends to be prepared for these kinds of situations. I realize that Andy Advocate's role in particular may come across as rather harsh, maybe even cruel, if you will, to some viewers. But he is obligated in his role as an advocate to see to it that the patient's wishes are honored. Unfortunately, that's uphill in our society oftentimes. It's with the utmost care for the patient that he is trying to enforce her wishes. Let me say as a footnote that the court will uphold the advocate. The statutes are with the advocate, and don't be afraid to take this to court if need be. That may be your last recourse. In this kind of situation, you can get a matter like this in front of a judge
within a day or two, no matter how jam-packed our court system is. They make exceptions for exactly this kind of case. So don't be afraid to take that legal recourse if you have to. I hope you don't have to, but if you do, that's what the statutes are there for, and they clearly support the advocate, the person with legal medical power of attorney. And you may know that if the patient's wishes are not being honored, Final Exit Network may help you with a lawsuit if necessary. Patricia, I want you to know, had expressed her wishes to her family over the years, but had been unable to win them over to her point of view. Let me say also that we held all of our conversations in front of Patricia patient. You may want to discuss this among yourselves, but in our case, it was made clear by Patricia that she wanted to be part of all conversations about her conditions, her treatment, or lack thereof. And that's the way we followed it out. I know some people would prefer not to discuss these kinds of things in front of the patient. But again, we were honoring the patient's wishes. And I happen to think that it's good that she does know, if she is that much aware of what's going on. And it's my understanding that hearing is the last sense to go in any case. So I would encourage you, as the actors did in these scenes, to talk to the patient. Act as if she can hear you, because we don't know whether she really can or not. So it was deliberate to have her included in the conversations as best she could be in her helpless condition. While we work with a Right to Die organization, Final Exit Network, you or your advocate may well use this not just at end of life, but any time you encounter a medical institution. Please note this: the national nonprofit organization Final Exit Network provides services to support having one's wishes honored. Again, Final Exit Network will take on legal challenges if one's wishes are not being followed. The network may even have people certified as advocates for you to serve in this capacity in the near future. Finally, you may be seeing this video as part of what we offer as advocacy training, our extensive and comprehensive training on how to get your wishes honored, providing specific instruction about how to be a good advocate for yourself and or for others. If you're not seeing this as part of our advocacy training, know that that includes about 30 pages of printed handout material. It includes this video demonstration, role-playing, and much more. So if you or your group want to be further equipped with this training, please contact me at 520-235-5646. 520-235-5646. Thank you for your interest, and best wishes to you and to those you love. Available on YouTube. If you Google John Abraham Advocacy Training, that will probably come up. When we'll have a new one in a couple of weeks. I'm not sure whether that will be widely available or not. That is available on YouTube.
doctor is the attorney who will be with us next week, Beth Smith, Elizabeth Smith. She has supported Right to Die for a long time. She'll be with us next week at the workshop, and John has died, Patricia has died, and Earl has died.
Oh my gosh.
So Beth and I are the lone survivors
Wow.
of that videotape.
Huh.
Okay, now it's your turn. And don't be timid, don't be shy. We have to have some volunteers. Let me take your question or concern. Yes.
Well, do you have to have an attorney to go to court?
In theory, you do not have to. I would advise you to have an attorney. I happen to know 3 elder care lawyers here who do support Right to Die.
Okay.
Not that you have to use one of those, but they're all good.
Do you know what they charge?
It can be good to have an attorney to, grease the skids with the court, so to speak. And how much they charge varies. Probably, I'm guessing these days, $300-400 an hour.
Yeah.
What do your lawyers charge you guys?
That's about right.
Yeah, it's
Okay.
not inexpensive, but
Yeah.
hey, it's a matter of life and death.
So the attorney would know what recourse to get in.
How to get you in front of the judge as soon as possible. Yeah.
Okay.
Yeah. Yes, so the question was, do you have to have an attorney if you do decide to go to court? And your question,
In one
Diane.
of the scenes, they talked about, I lost my train of thought. Oh, I know. A review every year of the living will.
Oh.
Is that
Yeah, that's why we have this workshop next week, next Saturday. It's important to update these documents. Your wishes may change, procedures may change, but more importantly, most importantly, at least initial or sign and date them again every year.
Oh, okay.
That shows that these are consistent, rational thoughts of yours. You're not saying withhold treatment just because I'm depressed this week. So at least sign them and date them every 6 months to a year.
Okay.
Let me take Cheryl and then Ann.
But they don't have to be notarized every 6 months.
They do not have to be notarized every time,
Okay.
right?
That was my question.
Okay, they do not. Although we hope to have she's having surgery Monday, but we hope to have our notary volunteer with us next Saturday too. If you have your documents and you need them notarized, we're hoping Carol can make it. So
We have an attorney coming next year.
yeah, Beth Smith, the attorney, will be there to answer questions and whatnot. She's not a notary though.
No.
Yeah. Yes. Ann.
The documents that we need to bring next week, are they in here or do we need to go someplace?
They're not in there. There is direction as to how to get them in there.
Okay.
I will also have all the state forms there next week. I'll have all the Arizona advanced directives.
Okay.
Okay. Anybody else? Let me just ask, how are we doing so far? Any other questions or concerns? Ann?
Can I bring someone next week who hasn't been here today?
You could, yeah. The
And I'll
cost is
explain to
about
her-
$6,000, but yeah, we recommend people come to this first, but it's not necessary. You could bring, who are you thinking of bringing? None of my business.
A friend, and actually she and her husband were involved in end of life guiding a long time ago.
Oh.
But I'm concerned about her health now, and I'm
Okay.
going to start advocating to her, get on this, and so,
Okay, yeah, bring them,
okay.
yeah, yes.
It's a good idea to review the forms before you
Right.
come.
Okay.
Because there are a lot of questions in there that you need to think about.
Yeah, think about this ahead of time. And in your handouts, which I did not dwell on today, you've got the values worksheet, you've got the Methodist work form. Those will help you determine what your wishes really are. What do I want? What don't I want? And again, you'll get these 7 pages of considerations and phrases that you might want to consider including in your living will. So sure, yeah, you could bring them there. Let me know ahead of time. You have my number in your folder there on my card. Please let me know their names if they're coming next Saturday. Okay? Any other loose ends? Anybody else? Yes.
What happened to the advocacy training that was established at the time and people were sent to Colorado to train for that?
Sent to Colorado?
Yeah.
Well,
That was during the time when this video was made, because I saw that, and I saw the actual, at the meeting when they rolled in, you should know that you rolled in on a gurney. The old man supposedly had prostate cancer, now he had a stroke, and the same scenario played. That was at our meeting at that time.
I'm not sure I understand the question. Can somebody help me?
The advocacy training.
This is what we call advocacy training.
No, she's talking about historically something Penn has done in the past.
Oh.
That they're talking, that they talked to us about doing again, but apparently it's not happening now.
And they were certified advocates, and you could just go and have them hired.
Oh, okay. If I understand this, Final Exit Network, as I mentioned earlier, will help you sue if your wishes are not being honored, okay? And we do support having your directives honored. We do not supply advocates, and I'm going to say this later, but you can only have, again, these things vary from state to state, but you can only have one advocate at a time, one person with power of attorney for health care to speak for you. You can only have one at a time, but if you say you want your sister Susie who lives in Louisiana, but you could name somebody here to be it initially. And then when Susie gets here, she could take over. So, although there's some reasons I'll get into in a minute about why not to have family involved, but I'll get to that. So you could have a primary, a secondary, and a tertiary, but only one at a time. We do not provide advocates. I do it for a few people. I charge money for it. I am now power of attorney for, I think, 4 people. And I can only take on a few at any given time. Right now, all of them are not failing. They're doing okay. But if they fail, I mean, it can be almost full time that I'm with them in the hospital and whatnot. And I monitor, what they're supposed to get, when they're getting it, how much they're getting, and all of that. But I do charge for it. We do have a few people who have been through this training several times who have volunteered to be your advocate. So if you want to contact me about that, I may be able to put you, I think Jay Fleur is one of them.
No, I also have too many.
Oh, yeah, she has too many already, yeah.
That's one of the reasons that the socials are really helpful, because you get to meet other people in a casual way. We have people do several sessions where they get to know each other, so that they can find out who that is and what the information. They can meet outside of these meetings and get to know them to find perhaps an advocate that might work with you.
Yeah, that's the small group social gatherings that I mentioned. And of course, you need to choose the right person. I mean, we're talking life and death here. So you want somebody you get along with, needless to say. Now, Final Exit Network recently discussed with me the possibility of certifying advocates, having them certified. And I have a friend, a fellow thanatologist in Wisconsin, who has grief counselors certified, that sort of thing. He does a couple of those through the University of Wisconsin. And unfortunately, Wisconsin is full. They said, no, we can't take this on now. But Dr. Lohman here is a retired professor from the U of A. He is going to look into having the University of Arizona consider certifying. We want them certified by a academic institution. People who are trained to be healthcare advocates. And so we may, in the future, have those. We don't yet, but we are just starting to look into that. Does that answer your question?
That's good.
Okay.
2 more questions.
Yes. By the way, there's no such thing as a dumb question, okay? Except maybe the one you don't ask. I think it was you, and then, okay, yes.
Would having an official legal program to certify advocates weaken the position of somebody who has a power medical attorney, but is not certified?
I don't think so. I've never heard any indication of that. They're still fully empowered, even if they haven't had the training. Yeah, and that's virtually everybody these days who has not. There is nowhere that I know of that does certify people to do that. As I said, we have a few volunteers, and you can meet others through our small group social gatherings, as Jay Fleur pointed out. Yes, Ann had a question.
I was power of attorney for both of my parents, and it went really well. But I think I heard you say that isn't a good idea?
I'll get to that in a moment.
Okay.
Ann saying I had power of attorney for my parents, and it went really well. I'm glad it did.
Yeah.
I'll get to that in a moment.
Okay.
Okay. Anybody else? Okay, now it's your turn. And I'm going to have Jay Fleur, you're going to do the role playing. You're going to be the doctor, the patient, the advocate, and so on. So we need a kind of maybe 3 or 4 people at a time. Jay Fleur will take it from here.
Okay, good. We'll role play some scenarios, and Tim is handing everybody a copy. We're going to do this with 2 different scenarios. And so, of course, we need doctors, we need the patient. That's really the most difficult part. You have to do that. So,
let me add, even if you're not up front doing the role play, you need to pay attention. We're going to want everybody's input and comments and feedback about this as we evaluate what we did.
good. I'm just trying to make a little room here. The bed for the patient, and they're going to be looking sickly. Tim, give me 1 copy of that. So I'm going to read it to you. You're all reading it. So Jack is 70 years old and has been in a coma now for 2 weeks already due to a car accident in which his wife died. Without the ventilator and feeding tube, Jack would die. His sister Mary flew in from Florida yesterday, and brother Tom lives nearby. Jack did not designate anyone to be his medical power of attorney. Mary tells the doctor that Jack has told her many times he would never want to be kept alive artificially. But brother Tom said Jack never mentioned death to him at all, and Tom believes Jack will recover given time, saying he has heard of such cases. But the doctor explains that Jack's brain is damaged and has only a slim chance of recovery. The longer he is in this state, the less chance Jack has of recovery, says the doctor. So that's our first scenario.
He's Jack.
Yeah.
I'm glad that Jack's family is here. I've been the attending physician, and briefly, his situation is that his brain is severely damaged. He has a very slim chance, if any, of recovering, and the longer he stays in this state, the less the chance of his ever recovering is. As far as we know at this point, he never filed a medical power of attorney with anyone, and we're glad, we here at the hospital are glad that you're here to help give us guidance in this situation.
I've had many phone calls with Jack Doe in the past, and he has told me so many times he does not want to be kept alive artificially. He has gone over that, and I know he feels very strongly about it.
Well, listen, doctor, I live in town. I've never heard Jack mention death at all, one way or the other. I'm glad that you were able to keep him alive, and I think you should keep him functioning as well as you can.
Well, of course, this puts me and us here at the hospital in a difficult situation. Jack obviously can't speak for himself, he left no directives, and we have two family members here that are really in disagreement. You said that he spoke about this many, many times with you, and yet you say that he never mentioned it at all. There seems to be sort of a disconnect. Can you think of any reason why possibly he never discussed it with you?
No, I can't, but a lot of progress has been made, and everybody recovers from wrecks. I had an 8-year-old niece that recovered from a coma, and I heard they put a lady's head back on that was in an automobile accident last week.
Well, that's a new one. This is a Jack's problem. But Jack has, as I said, has spoken to me so many times. This is a family feeling. And it isn't that I don't live nearby, but I love Jack and I keep in touch with him and I know how strongly he feels about this.
Have you, in speaking with Jack, ever voiced your opinions as to what might happen in a situation like this, or what your own wishes would be?
No, we never have. We prefer not to talk about death or unpleasant things, and we have never spoke about this, and I never made my wishes known to Jack, nor his wishes to me.
How long are you thinking that we should leave him in this state where he is totally unresponsive, is declining day by day as we've seen, and our medical prognosis is that he will not recover? So how long do you feel he should be maintained in this state?
Oh, I feel as long as he has a pulse and is breathing on his own, he should be kept alive.
Just like a vegetable, is that it? Keep it going and put it in the refrigerator and keep it fresh. And then if it doesn't get too rotten, then you can put it in the garbage. Is that what you're saying? You can't let the guy go in peace in the way he wants to go, with the family around him, the people who love him and care for him?
I'm seeing two very strongly held positions here, and perhaps I should step aside for a minute and let the two family members discuss this between themselves. Ultimately, I'm the doctor here. You have certainly standing as family members, but in the absence of specific legal guidance, I will end up making the decision.
I have no official control over this. All I know is how Jack feels, and I think you should respond to his wishes. It's his life, his choice, and I think he has made the choice. And I think the decent thing to do is let him go in peace.
Well, sister and doctor, we must be cautious of playing God, though. We cannot decide for Jack.
Kind of situation. Do you have any ideas what you have as a concern? How about just concern about who's going to take care of Jack, who's going to pay financially for all that care, who's going to oversee it? There's a definite answer to that. Something that came up for me out of that was with the medical team at the hospital, perhaps talk to other people in the hospital, their legal team, as to what they need to do. If the family cannot come to an agreement, I don't know about that, what the procedure would be.
How long would a hospital allow this impasse to remain? I mean, at what point does a hospital say, enough, we're doing such and such?
Right. So she's asking, how long would the hospital let this kind of disagreement go on? Because they legally have the care of this patient. And what would the hospital, and how long would that be? Is that your question?
Yes.
I don't know that. Does anybody know an answer to that?
It depends on how much fear they would have about legal action from the brother.
So they'd be concerned about legal action from somebody's brother coming to sue the hospital. But that would
Yeah.
Wouldn't there be legal precedent on this? This has had to come up many times.
Yes, I bet you're right, George. He's saying that there's probably some, this has come up for most hospitals sometime, and they may have their own procedure. Mm-hmm.
I'll bet I don't have the answer to that question, but I'll bet they also want to know who's going to pay the bill the longer this goes on, you know? I'm sorry, go ahead, Jay Floyd.
That's good.
And somebody give her that.
Other.
I'm sorry.
No, you took, that's what I was gonna ask, who pays the financial part?
Yeah.
The hospital, the doctor? Because if you say you gotta take care of, the hospital says we can't do anything, they should be responsible to pay everything. And they can't go to Medicare and go to insurance then, and that should be in writing somewhere. But
I think so.
So it sounds like, I'm guessing that between the brother and sister there, suppose each one of them says, I'm not paying for this, but I want you to do such and such. At some point, the liability, the financial liability from the hospital, I'm betting would be the final determinant in this. And the lawyers, the hospital lawyers would step in and say, okay, 3 days, that's it.
That's it. Yeah.
When you go into the hospital, you sign and say that you, or presumably your estate, is responsible for any bills that are incurred. I mean, they have that.
But what if you go in and you're not conscious?
So, hold on a minute. So, Tim says that when you go in the hospital, you sign a piece of paper with all you give away your rights. And Cheryl is saying,
What if you go in and you're not conscious?
yeah, what if you go in and you're not conscious and you can't write?
I don't know what they
I don't know either, but I'm sure that the hospital has their procedure for that, because it must happen more than once.
So next week, we have a lawyer coming in who might know the answer.
That's right, you can ask her. Okay, good. Are we ready for the next one?
Okay, next role play, we
Next.
need volunteers.
All right, let's go. We need a patient. This is Betty. Oh, come on up, Betty.
How many Betty?
She's Betty. All right. So I'm going to read it real quickly. Betty is only 23. She has MS, and her breast cancer has spread to her bones and lymph system. She is in severe pain. She has stated she wants to stop all chemo and other treatments. Because the pain is so severe and the meds are not effective, they have sedated her to unconsciousness. Her prognosis is grim, but she has not been diagnosed as terminal yet.
Gosh.
Her brother, Bill, lives in town and has her medical power of attorney. Her parents, Ralph and Margot, live out of state and insist everything needs to be done to keep her alive. They've driven 800 miles and want to be with Betty because they remember Betty as a lively and energetic girl, thus believing she'll improve with more treatment. They believe because they are the parents, they should have the right to decide about her care. What is the dilemma here? Yeah, and what are the prevailing issues? We're going to talk about that a little bit more after we role play a little bit. Okay, we need a father, Ralph the father. Who will take that on?
Come on, Dad, step up.
Step up. Larry, you want to try that?
No.
No? George?
No.
Oh.
I want to observe, not
You
be
want
part
to
of it.
observe. Okay, we need a father.
Come on.
Come on.
You didn't say a word.
I don't say a word.
You want to try this?
I'd rather observe.
You ready? Boy. Wasn't it fun for the people who did it last time? It was easy. It was fun. Okay. We need a father.
I'll be a father.
Yay! Good, Betsy. So here's your little cheat sheet. All right, we need the mother. How about Margot, the mother? Betty has a mother. Ann?
Mom, we need a mother.
We need a mother. Can't start without her. Yeah, it's very easy. You want to try being a mother? How about you, Diana? I'll give you this little cheat sheet. It makes it easy. You just read that and act it out. Yeah, I know, it's too much to remember. That's why I'm giving you all these little cards. Okay, now we need a doctor. We need more people in this one. Okay, doctor, doctor. Going once. Going twice. Step up, step up. John.
I'll do it if no one else goes.
Huh?
I'll do it if no one else goes.
There you go, see?
Not attached.
Yeah, doesn't matter. Okay, and so we need one more person, and that's the brother. And you want to give yours up? Okay, so we have mother who needs to be replaced. Who's mother? Who will be mother? See, this is like pulling teeth. Janice, will you be the mother? Would you try?
This is kind of close to home.
Oh, okay.
Hi, I'm glad you're all here. We need to make some decisions for Betty here, and I need to explain that the prognosis is really pretty bad. She's in so much pain that we have her sedated to the point where she doesn't know about all that pain. She's not terminal, but the pain meds just aren't working when she's conscious, and that's why we have her in the state that we have her in. So I'm anxious to know how you feel and what you need to decide, and if it's time to let her go.
Well, I'm Betty's mother, and my being family, I think I get to make this decision along with my husband and her father. She's just our little girl, and she's always been so energetic and loved life, and I think we need to try everything we can to keep my little girl alive, and I just can't imagine her leaving us, even if she's in pain, but I think you can find a way to keep her out of pain. I'm pretty sure of that.
Betty, this is Bill, and I'm here to represent your interests, as you've indicated on your medical power of attorney. I think it's important that we all remember, thank you, that we all remember this. Betty made a decision. She made a decision as to who would have the final authority in this instance. She had the opportunity to give the decision to the parents. She chose not to do that. So my role here is to be her advocate, not to indicate how I feel about it, but to indicate how Betty felt in this instance and what she wanted to happen in these circumstances. That's my role, and I intend to carry it out.
Well, again, as her mom and dad, I just can't believe that she would exclude us from this decision, even though you're saying that she had talked to you about it and you have paperwork. That doesn't really make any sense to me at all, and I want to know what the doctor thinks again.
Well, Mom and Dad, I guess one question I would have is, the best we can do for her is how she is right now. And how long would you want to leave her just in this state where she has absolutely no quality of life, and the prognosis suggests she never will have a quality of life again. So how long do you want to leave her in this state?
Well, I don't want to leave her in this state. I want you to make her better. She's so young. There's just no reason for her to die now.
We can't make her better. That's what I'm trying to explain to you.
Well, you don't understand as a parent, this is just going to break our hearts, because our little girl isn't supposed to go this way. She's supposed to go when she's a lot older, not like this.
But it's important to remember that this doesn't have anything to do with what the doctor wants, or what the parents want, or even what I want. What's important is what Betty wants. And Betty has indicated in a document which has been, which is a legal document, what her wishes are in this instance, and where I might want to keep her alive, that has nothing to do with it. Betty's indicated what she wants to do when she comes to a situation like this.
Mom and Dad, I totally sympathize with you. I can't imagine the pain of losing a child. So I totally understand where you're coming from. But I do think we need to listen to Betty's wishes and what she wanted, and she's put them in writing and made it clear, and she has a legal representative to stand up for her. So as hard as it is to let her go, that is what she wanted.
Maybe we should do that, or within the next 4 months or something, could have been added there, not terminally ill, for the next 4 months or something.
If I didn't have to follow the script, I would have said that she was terminally ill.
Oh, yeah. But then, yeah. Okay, Sam?
The trouble is, nothing was in writing. It said she stated she didn't want to be in this. How did she state it?
No, she didn't.
No,
She had a power of attorney.
There was no writing.
The brother had the medical power of attorney, and so he would have known. Right? Because if you are taking on being an advocate and medical power of attorney, it's very important that you really know that person and all their wishes and their family and what might come up, and so that's part of your job.
It certainly indicates the importance of a living will or something else that makes that so clear, regardless of specifics.
Right, so that if she's saying that how important it is that your living will is very clear and with as much detail that you could think of to put in there. Yeah, sure.
Regardless of how old you are.
Yes, regardless of how old you are. That's another reminder, like John says, everybody should have this available. Yes, Betsy?
Well, I think the issue of having in the scenario that she's not terminal is probably important, because I think that's the parents.
The parents are saying, well, you know, she's young and we think you should keep her alive. The fact that she's not terminal would be their argument that, wait a minute, she's not terminal. And then that has to be the argument from the other side that she will be terminal at some point. And I think that's a good thing to probably keep in there.
I think the importance, it brings the importance of letting all your family know your wishes, not just the sister, but the parents and any other brothers and sisters.
That's right, let people know, and you could Google the Conversation Project. I also have some other tools that can help you get these kinds of discussions started.
Isn't it also important to be certain that in the determination of the medical power of attorney, that there be very serious specifics in terms of under what conditions?
Well, yes, you want to be as specific as you can, but you can never anticipate everything. And that's why Sam said, well, there wasn't anything in writing. Even if there were nothing in writing, that medical power of attorney can decide whatever he or she wants to decide. That's why it's so important that it's somebody you literally trust with your life. Okay, we're talking life and death. Yeah, life or not, and who knows your situation as well as possible. Not just your medical wishes, but your financial situation, your spiritual state, emotional state, and so on. I mean, this is serious stuff. Yeah. Okay. One last comment.
But if the medical power of attorney states that if I am in a terminal situation, I would assume in this instance that if she has not been determined to be terminal, that the power of attorney might not come into play.
No. The person who has power of attorney for health care speaks as if they were the patient at that time. They can say whatever they want to say. They can contradict. what is in writing in a living will. Now, if push comes to shove and all that goes to court, I don't know whether the judge will uphold what is in the living will written down or what the power of attorney is saying that is contrary to that. But as far as I know so far, the statutes lie with the power of attorney for healthcare. Yeah. Do not have to be in agreement necessarily. Okay. Okay, well, thank you all for your role-playing expertise and your participation. Moving smartly ahead. And I know there were a couple questions I said I'll get to later, so basically 3 right-to-die organizations in the country. We're the only one that supports people who are not necessarily terminally ill. People who can no longer function for them and care for themselves, and they're terrified of the suffering that lies ahead of them. Existential suffering. And I mentioned this earlier. Nothing in this world will torment you as much as your own thoughts. Okay, here's what to do with the documents. You want to store them in all relevant places, maintain a record of where and to whom you give the documents. You want to give copies to your family, your friends, your lawyer, your doctor, any medical institution. You want 2 originals, one that you keep and an original that your person with medical power of attorney has. Your advocate should get an original. I sometimes say sign the original in red or blue ink to help it stand out as an original, but so 2 of those. Multiple personal sites, a home safe, on a refrigerator, in your car, in your glove. Some people even carry them in their purse. Family, friends, doctor. Every hospital has what they call a patient advocate. Now, mind you, that person still works for the hospital, but you make sure they get a copy of these directives. You or your advocate, make sure they get that. The patient advocate. Your personal attorney, preferably somebody familiar with elder law. You or your advocate always want to obtain a copy of patients' rights statements from medical institutions providing care, and study that document carefully and give copies of that document to people who also have your advance directives, anybody involved in your care. And hospitals and nursing homes both have statements of patients' rights. These documents can be witnessed or notarized. Do both. Do both. You don't want to keep them in a safe deposit box. By the time they're accessed there, it's too late. So, it's best if your advocate is legal with medical durable power of attorney, thoroughly familiar with your wishes, physical, emotional, financial, spiritual state. You want to communicate often and give specifics, at least annually, introduced to others in your care, and has the original signed documents. Now, this came up earlier, Ann asked that. You may want to consider it not being a relative. And I say that because I know 2 women in Tucson who were the advocate for their parents, their mothers in these cases, and they both did what mom wanted, which was to withhold treatment. That was all well and good. However, to this day, they feel guilty. They still feel guilty about somehow being complicitous in their own mother's death. So you might want to consider having somebody, not that your friends don't love you too, but having somebody who is not an immediate relative. And the same is true with couples. You know, if you have been happily married and living in marital bliss for 40, 50 years, and you have the other person's power of attorney for health care, and you've agreed intellectually, yes, this is what I want, and I'm going to withhold treatment for you if that's what you want, and so on. It's one thing to say that, it's another thing to do it. And in fact, You know, I may not want to let my wife go after 40 or 50 years. I may not let her go. I want to keep her. So there are reasons to consider. I'm not saying don't have it be irrelevant, but it is something to consider. Obviously, someone you trust implicitly. You want somebody who has people skills. You want somebody who is articulate, personable, and charming, such as myself. Yeah, you want somebody who can communicate well and so on. But you also want somebody who is articulate, who can be assertive, and in fact, can be a son of a bitch or a witch on wheels if necessary. You know, who can deal with a situation if push comes to shove. So you want a tough cookie, somebody who can be a tough cookie if need be. Okay, I told you already, you can only have one at a time, but you can have a secondary or tertiary person. They're all state specific. I told you, I elaborated on this earlier, have family agree or don't include them. Sign and update every 6 months to a year. Insist that you or your advocate, even in this day of electronic charts, there's not so much paperwork these days. But 10 years ago, if you were in the hospital for a week, the paperwork would be this tall, stack of papers this big on your medical records. Whose medical records are those, by the way?
Yours?
Yours, that's right, they're yours. Now, even if it's electronic, you or your advocate should demand, I seldom like to say should, it would be best if you or your advocate demand every day that your directives be put on top of the medical file, even electronically. You demand that every day. Why? So they don't get buried and lost. It keeps them in the mind of the caregivers, in the minds of the medical personnel. So you insist, that is some recourse you can go to if your wishes are not being honored. I mentioned the hospital patient advocate. Every hospital has one. You could go to them. Ethics. Every hospital has an ethics committee. They can meet within 24 hours notice by phone or by email or conference call and whatnot. You can ask to address the medical ethics committee. You can go to the hospital administrator. Now, mind you, you may have to go through a layer or two of administrative staff to get to the administrator, but go raise hell with the administrator if you have to. And let him know or her know what's going on. And as we have already mentioned, court. Okay? And you and possibly Final Exit might help you, network might help you sue for abuse and negligence. Abuse and negligence if your wishes are not honored. So you do have some recourses. All right, ready? Medical mistakes. Third leading cause of death, 30 million wrong prescriptions. Every year, 30 million wrong prescriptions are written. 1 out of 1,000 lab specimens is mislabeled. See, this is all stuff that you or your advocate needs to monitor, needs to stay on top of. 1 out of 10 diagnoses is wrong. Let me back up here. I mentioned earlier, we support those who are not terminally ill. People with neurodegenerative diseases like ALS or Huntington's can suffer for years. There's some pain that no medication can touch, like deep bone pain from cancer or trigeminal nerve pain in the face. My friend Doug, his daughter was ill with cancer. She was in her mid-20s. She was seriously ill. And he went to visit her in the hospital one day and went to sit on the edge of her bed. And between him and her, there were 7 pillows. 7 pillows. He went to sit on the edge of the bed. She cried out in pain. You know, that's how severe it was. and nothing the hospital could do to alleviate that pain. There are people who can no longer function or care for themselves, and they're terrified of the suffering that lies ahead. There's a certain irony. They fear death, so they want death. It was Hamlet who said, "If it were done, then 'twere done well. It would done. If it were done, then 'twere well. If it were done quickly." A friend called his longtime veterinarian to ask about hastening death. The veterinarian confides that he used to worry even about euthanizing animals. And at one point he asked his Episcopal priest, "Is God okay with me taking life this way?" And the priest told him that he was responsible for protecting life, and that also meant protecting life from suffering. That said, and 30 years of fervent thank you notes from his patients' families eased his mind. And then the veterinarian watched his mother's slow and painful death, and he kept thinking, I would never let one of my animals suffer like this. Many who are not yet terminally ill seek out the services of Final Exit Network, and includes people suffering from debilitating diseases such as cancer, neurological diseases, Lou Gehrig's diseases, Alzheimer's, Parkinson's, Huntington's, motor neuron diseases like MS, muscular dystrophy, respiratory illness such as emphysema, degenerative afflictions such as cognitive heart failure, or congestive heart failure, stroke, AIDS, Guillain-Barré syndrome, and others. Only about 5% of people who hasten their death, and this is true even in states where physician aid in dying is legal. Only about 5% who hasten their death do so because of physical pain. Very few. It's all this existential suffering that is the main reason. Anxiety, abandonment, anticipatory grief. After all, I'm faced with losing everyone and everything. Becoming a burden, confusion, delirium, dependence on others, depression, fear, futility, hopelessness, loneliness, loss of dignity or purposefulness, psychic pain, tiredness of life, unworthy dying, and more that may accompany the dying process. I mentioned financial concern earlier as well, yes.
So, John, under those circumstances, I know of two circumstances of 75-year-old women who perfectly healthy, totally and completely, and one I heard from my PCP, but they felt that they didn't want to go on. They were tired, they had no purpose, and they were done. Does Final Exit work with people like that?
Okay, the statement was I have two friends who were in their, mid-70s, who were just tired of living. They were perfectly healthy, but just did not want to go on for some of these kinds of existential reasons. Okay, does Final Exit Network support that? The answer is yes. We've made a couple of changes lately. One is we used to support, in some cases, people with mental health problems, like long-term severe clinical depression, not temporary depression, but the serious stuff. We no longer do that. We won't support that. We also now require that you discuss this. If your wish is to hasten your death, you must have discussed that with your family. I've talked with you already about that. We have been known to support the criteria of tiredness of living. Okay? Now, you will have to submit some medical documentation that something is failing, but it could be your hearing, your vision. It doesn't have to be something major, and our medical committee will screen you. So the answer is maybe those people would be supported. They say, I can't get out and do what I used to do or enjoy doing, and so on. So the medical committee screens them, and if they're approved, screened, they then qualify for exit guides and are told exactly how to proceed if they choose to hasten their death. Now, you still, in order to do that, one still must be physically able to acquire, although it's all delivered to your door, you gotta be able to order it either by phone or online. You have to be able to manipulate the equipment, and you have to be mentally sound. Our two criteria, basic criteria, are you must be an adult and you must be mentally competent. Some people lose what we call the window of opportunity. Again, we never encourage anybody to hasten their death, but if that's their choice, you want to do it while you can. You don't want to become too demented, too far gone mentally to be mentally competent, nor do you want to be too frail to manipulate the equipment. So you want to do it while you can. Does that answer your question?
Yes.
By including the terminal criteria in the states that have physician aid in dying, those laws are ridiculous, if you ask me. And now we have 6 states. Hawaii, I think, Hawaii is about to become another state that has physician aid in dying. Oregon was the first. It's been there over, what, 22 years now. This has been introduced in Arizona for at least the last 20 years, never gets anywhere. It's not going to pass here in my lifetime with this legislature that we have. All the laws are modeled exactly on the Oregon law, the first one. And the 6 states that now have this, there are a lot of problems. My favorite phrase is, we need to terminate the terminal aspect of those laws. Let's terminate the terminal. Because one of the criteria is you have to be terminally ill. Well, by the time 2 doctors say you have 6 months or less to live, you might as well have 1 foot in the grave. You're pretty far gone. And they're reluctant to make that diagnosis in the first place. That's one of the problems. There are many others. Some places, even in Oregon, where it's been legal for so long, it's not that easy to find a doctor who will comply. Whole hospital chains and doctors have opted out of participating in this. It ain't that easy. And the prescription, they write you a lethal prescription, you have to get it filled, and it's not that easy to do that. Some drug companies will not provide you with the lethal prescription. They don't want to be complicit in that. But moreover, the prescription can cost thousands of dollars. Not covered by health insurance. Now, our inert gas method costs about $300. So there are a number of difficulties with those physician aid and dying laws. They just don't go far enough. They don't help, most of the people that Final Exit Network helps would not have qualified for physician aid in dying in those states with all of their criteria. So we support a far wider range of difficulties. Okay? So, by including the terminal criteria, such physician aid and dying laws exclude many who may wish to hasten their death due to hopelessness and interminable suffering experienced far in advance of being arbitrarily deemed terminal. Such as those with early stage Alzheimer's. We will support early stage dementia, progressive disorders like ALS, MS, much more. Those with dementia may have to wait until it is too late, being diagnosed as incompetent, to give informed consent for physician aid in dying. Moreover, the term terminal is not always justly applied. Doctors don't have a crystal ball. And I have a friend whose mother was in a nursing home suffering and withered away. The mother withered away to she weighed only 58 pounds. And yet the doctors refused to declare that she was terminal. We need to terminate the terminal. mentioned mistakes as causes of death.
Could I ask a question regarding?
Yes, sir, Larry.
The second item there is alarming. 30 million wrong prescriptions.
30 million wrong prescriptions a year, Larry says, is alarming, yes.
How was that determined?
I don't have the source for that here. I believe it though. I'm sorry, I don't have the source. That means, yeah, you would probably know if you got a wrong prescription. The doctor prescribed XYZ, but they gave you ABC instead. That's what that means. It's not that they were written wrong, they were filled wrong. You follow me?
That's probably clerical errors to the wrong patients.
Yeah, you got somebody else's prescription, it was meant for someone else, but it went to you, whatnot, yeah. Human error enters into the picture. That's the best answer I can give you right now. Modern dying involves a struggle for control. Some doctors fear failure when they cannot keep their patients living. Families filled with grief and sometimes guilt often have their own strong views on how and where patients should die. As I said earlier, most of us, not over 90% of us, want to die at home, and that can lead to struggle with doctors who may see such assertions as an affront to their authority. The needs, unquote, the needs of the dying patient are defined and thus filtered through the views of family and healthcare professionals. Well, who is the best person to determine your needs? You, right. 1 out of 1,000 lab tests, specimens mislabeled. Okay, so 1 out of 10 diagnoses may be wrong. When you're in the hospital, you or your advocate needs to ask for a daily list of medications and the doses thereof and check them. And if you're hooked up to tubes, you want to see where that tube leads, to what it's connected, make sure it's the right thing, and what the dosage of that is, and make sure that's correct. The average time, by the way, with an emergency room, average wait time in the ER is 49 minutes nationwide. One tip I can give you is doctors talk to doctors. So if you or your advocate have the luxury, I happen to have my doctor's cell number, okay? If you or your advocate can contact your doctor and you're on the way to the emergency room, have your doctor call the emergency room ahead of time. That's one thing that might help. Sam, again, Dr. Sam is agreeing. Doctors talk to doctors. The wait can be, hours. That's no... Cheryl's been there many times, 4 or 5 hours, and I've been there with her. Yeah. It can be interminable. Patients have died while waiting in the emergency room. So that's one tip I can give you. Okay, I already told you, trace the tubes to their source and so on. What happens to your digital data after you die? Many people don't think about this. The companies that keep our data have confusing, inconsistent, or non-existent policies about this. You can use a digital estate service. You can name a digital executor along with a regular executor in your will. And I just remind you that things like a 401k and life insurance are not covered by a will. One question I get asked a lot about life insurance, nobody has asked it today. If you choose to hasten your death, what about life insurance? Yeah. The bottom line is you need to read the fine print of your policy. But usually, you got to read your own fine print, but usually those policies are written in such a way that if your cause of death is deemed to be suicide, a term which I avoid because of a lot of negative connotations. In my book I have about 30 better terms. My favorite is one that Tim Lohman came up with compassionate, deliberate life completion. But if your cause of death is ruled suicide, and that's more than 2 years after you have taken out the life insurance policy, it's a moot point, usually. But again, you gotta read your own fine print. Now, and again, this isn't a seminar about how the right to die, but some people do it overtly, others do it covertly. Overtly, they leave a copy of my book there, or the book Final Exit by their side. They leave a note, this is what I'm doing, why I'm doing it, I've thought about it consistently, I am of sound mind, nobody helped me, blah, blah, blah. And they leave that by their side. They leave the hood on. The nitrogen sits right there. Others do it covertly, where after they die, somebody else removes all of the equipment, nobody knows how they died. So it varies, but I got into that by talking about the life insurance, so that they may or may not know how you die. Okay, I'll tell you these, so you may not have to have them. This was a study done by a hospice nurse who polled thousands of hospice patients. Now mind you, these are patients who have been told they have 6 months or less to live. There was the 5 regrets of the dying. There was no mention of more sex or bungee jumping. One was, I wish I'd had the courage to live a life true to myself, not the life others expected of me. That's the most common, being true to thyself. Another was, I wish I hadn't to work so hard. That was virtually all men, to be sexist about it, but virtually all men, I wish I hadn't to work so hard. You know, it reminds me of the joke, you'll never see on a tombstone, I wish I had spent more time at work. Right? Or I like the other one, I told you I was sick. I wish I had had the courage to express my feelings. My guess is maybe men more so than women, but nonetheless, I wish I had the courage to express my feelings. I wish I had stayed in touch with my friends. You know, that's so true, and it's not easy these days. We get flung so far and wide, scattered across the country or beyond, but it's important to keep in touch with family and friends. You know, I have, I don't know, a whole lot of acquaintances, but I could count on one hand, probably, my really close friends. I wish I stayed in touch with my friends. I wish I had let myself be happier. Wish I had let myself be happier. So don't be a doom seeker. The goal is to die with memories, not dreams. Live your life that way, right? I always give a plug for Funeral Consumers Alliance. Who here is a member of Funeral Consumers Alliance? Okay. I happen to be slightly biased. I've been on the national board for years. I just got off of it. I'm on the Arizona board of the state affiliate of Arizona for Funeral Consumers Alliance. It's a nonprofit organization that is dedicated to protecting a consumer's right to choose a meaningful, dignified, affordable funeral. It's the only organization that does so. And it can save you thousands of dollars on a funeral. In fact, we recently negotiated with a local funeral home the price for a simple cremation. It's nationwide, so if you're a member of FCA, you die in Omaha on vacation, they can help you find the most reputable place to deal with for those kinds of arrangements where you die. All right? The website is www.funerals.org. Another question? Was it Larry who had the question?
Yes, just a quick one.
Yeah.
Does that organization also help if a person wants a green?
Does that organization also help if someone wants a green burial? Yes, they can help steer you to who does that. In this area, the only one I'm aware of is the Marana Mortuary. Has an area where you can be buried in a shroud and simply put in the ground. That's the only one I'm aware of here, but nationwide it varies, and there are whole fields where you could just go be buried in the field, nothing surrounding you. You know, yes.
What funeral home was the one that you just mentioned?
Adair, A-D-A-I-R, Adair Funeral Home is the one that we recommend here. And we put out a price list every year. It was FCA that was responsible for the, what is called the funeral rule, which Congress finally passed, requiring funeral homes to make price lists available. They didn't used to do that. And there has been, over the years, notorious exploitation by the funeral industry of those who are in distress and in a time of need. But now they have to get prices. Now we're working to requiring to having a new funeral rule passed by Congress, requiring that web information give price lists and so on. So none of this applies to the internet yet, but we're working on it. And the abuse has been significant. I remember back in the 70s, I did not usually accompany families to the funeral home, but I did this one. And you know, the most costly coffin, by the way, I don't call them caskets. Casket to me is something you find at the bottom of the ocean filled with gold doubloons. Coffin is what you put a person in. So anyway, the most brightly displayed front of the pack coffin is the most expensive when you go into funeral home display room. Well anyway, I went with this family and they wanted an inexpensive coffin, and you can get a cardboard container for that matter. And the funeral director said to them, well, we could sell you that one. Of course, we'd have to break his legs to fit him in there.
Oh,
You know, I mean, that's the kind of stuff they did to get you to buy something more expensive. I highly recommend you consider Funeral Consumers Alliance.